in this third Sindh chapter grand round of Pakistan Association of Cardiovascular and Thoracic Surgeons. Pakistan Association of Cardiovascular and Thoracic Surgeons works with great objectives for healthcare and betterment of patients with cardiovascular and thoracic diseases. It also aims to provide a platform for research and development in the field of cardiac, vascular, and thoracic surgery. So grand rounds being an important part of it, the purpose is to disseminate knowledge, share the experiences, change the traditional way of thinking and behaviors, and certainly to improve the patient outcome. So formally proceeding the program with the name of Almighty, I request Dr. Fahaduddin Sheikh to please come for recitation of holy verses from Holy Quran.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم آمن الرسول بما أنزل إليه من ربه والمؤمنون كل آمن بالله وملائكته وكتبه ورسله لا نفرق بين أحد من رسله وقالوا سمعنا وأطعنا غفرانك ربنا وإليك المصير لا يكلف الله نفسا إلا وسعها لها ما كسبت وعليها ما اكتسبت ربنا لا تؤاخذنا إن نسينا أو أخطأنا ربنا ولا تحمل علينا إسرا كما حملته على الذين من قبلنا ربنا ولا تحملنا ما لا طاقة لنا به واعف عنا واغفر لنا وارحمنا أنت مولانا فانصرنا على القوم الكافرين صدق الله العظيم.
Thank you, Dr. Fahad. For welcome note of today's event, I would like to request Dr. Syed Danish Hassan Zaidi, Assistant Professor, Cardiac Surgery, Dow University of Health Sciences.
Respected surgeons, Assalamu alaikum. I welcome you all to the third grand round of Pakistan Society of Cardiovascular and Thoracic Surgeons Sindh chapter on behalf of Dow University of Health Sciences, Dow Medical College, SMBBIT Trauma Center, and Gambard Institute of Medical Sciences. Today, we have gathered here due to the effort of our President-elect, Dr. Hasna Sharif, who in our terms, we say that he has taken the aortic clamp off the society and the society is perfused with new blood. This is our term. Here I would also like to mention that when we announced the meeting and we requested for the case report, we got an overwhelming response. But due to shortage of time, we selected only 5. I apologize for this. But we want our residents and I encourage our residents to resubmit their cases in the next upcoming meeting, because your cases are, all of your cases are worth listening to. I conclude my talk by sharing with you an incident that happened with me a few months back on social media. Can you please? So this is a tombstone of a Pakistani. The story behind this tombstone is this is a tombstone of a Pakistani child who went to India for cardiac surgery, and he did not survive. On social media, they have shared this picture, and they have asked that They wanted to visit the grave again, and they have lost the documents. So what happened that I sympathetically commented on this post that that all of the cardiac surgeries except heart transplants are being done in Pakistan. So no need to go to India. My comments received some very derogatory remarks, and which led me to think that people are over here, our masses are not aware that we are doing such surgeries and we are doing it very well. I suggest that we should spread more awareness regarding cardiac surgery among the people, as we all are doing our efforts in limited resources. Thank you.
Thank you, Dr. Danish. Now I would like to invite one of the distinguished name in the field of cardiothoracic surgery, the President-elect of Pakistan Association of Cardiovascular and Thoracic Surgeon, Dr. Hasnat Sharif, to please come and share his thoughts.
Bismillah ar-Rahman ar-Rahim. Thank you, Danish. Thank you, Dr. Hosh. Thank you, everyone, for attending today and making this possible, because I think it's you who make it possible, not us. We just organize it. And the participation shows that you come in here on a Sunday, leave your things, and be with us. All of this is a 20-year-old dream that I had when I left the USA to come here. They used to have intercity Boston rounds. And I thought that was a good idea. And we could replicate that in Pakistan. So the format that we currently have is not exclusive. We can change it. You don't need to have 5 case presentations. We could have a talk from a big person in the field of cardiac surgery. We could have mortality. If we get to that point, we should do mortality and morbidities. We should be open to discussion of all of these complications that we have in an attempt to improve our outcomes. We've changed the format a little bit for this meeting in the sense that we feel that we should empower our younger generation. This promotes all inclusivity and gives you a sense of ownership that this is your society. It doesn't belong to the people at the top. It's yours. You will take this thing forwards. Danish, Sanaullah, Hosh, and Dr. Mudassir have done a stupendous job by putting this together, because this was meant to go to Taba, and Taba, unfortunately, for one reason or another, couldn't do it. But perhaps we can do this in the next meeting with Taba. And I think because time is such an important thing, we're going to do it every 3 months. We're looking at August. So the next meeting should be in August, and hopefully if Taba takes the mantle, the baton, we'll give it to them. Very heartening is what's going on in KP. KP have realized that they can also jump onto the same bandwagon. And I'm very happy that the KP chapter is having its first meeting on the 27th. So I think if we have vibrant local chapters, that's what the society is all about. I think we don't have to wait for the whole year to come to the next meeting. 2 things that I need to mention right at the end are, one is we will start our membership drive, because I think unless we have a membership drive or the census, we cannot have elections. If you cannot have elections, you cannot have office bearers. You cannot have office bearers in no society. So we will start a membership drive. And last but not the least, I'm grateful to FarmEvo for doing this for us, because without their help and support, this would not have been possible. Thank you.
Thank you, sir. Ladies and gentlemen, time for honorable panelists to take their place. I would request one by one to please come and be seated at the stage. Dr. Sanaullah Junejo, Assistant Professor, Cardiac Surgery, Chairperson, Cardiac Surgery, Dow University of Health Sciences. Please, sir, come on stage. Dr. Iqbal Hussain Pathan, Associate Professor, Pediatric Cardiac Surgery, Gambard Institute of Medical Sciences. Dr. Ehsan Memon, Chief of Cardiothoracic Surgery, Tabba Heart Institute. Dr. Nasir Ali Khan, Assistant Professor, Cardiac Surgery, PNS Shifa. Dr. Misak, Consultant Thoracic Surgeon, Jinnah Postgraduate Medical Center. For fair assessment of the presentations, we have a panel of judges with us. I must introduce them. Dr. Muhammad Farhan Khan, Assistant Professor, Cardiac Surgery, Gambard Institute of Medical Sciences. Dr. Fiza Iftikhar Ahmed, Consultant Thoracic Surgeon, Shahid Benazir Institute of Trauma and SIUT. Dr. Vikram Kumar, Assistant Professor, Cardiac Surgery, NICVD. Dr. Muhammad Kaisar Aziz Khan, Assistant Professor, Cardiac Surgery, Liaquat National Hospital. And Dr. Najir Sikandar, Consultant Thoracic Surgeon, Darul Seel Hospital. Grateful for your presence. Before I call our first presenter, I must mention that we have 10 minutes. Yes. Please, Dr. Anam Asif, please come for your case. Thank you.
Assalamu alaikum. Good afternoon, everyone. I'm Dr. Anam Asif, thoracic surgery resident from JPMC. And the case that I'm presenting here today is titled as Can't Breathe, Can't Eat, a Neglected Esophageal Mass. How's it going to be next? It's not working. So I have got no disclosures to be purported. Well, starting a little bit about the background of the case before moving on to the actual case. So schwannomas are mesenchymal tumors that derive from the nerve sheath cells. And gastrointestinal schwannomas are the rare entity, accounting for only 2 to 6% of all the benign tumors in the GI tract. So I'll discuss few of the salient features of schwannoma here. That is, out of those 2 to 6%, 70% occur in stomach. So esophagus is the least common site, accounting for only 2% of those tumors. The most common location is upper to mid-thoracic esophagus and are reported in the 5th and the 6th decade of life. Most common symptom is the dysphagia, and the enucleation of the mass is the treatment of choice. So in the following slides, I'll discuss how our case was unique and how it did not follow this conventional pattern of the disease. So the case presentation, it was a case of a 41-year-old female, married, mother of 8. She was a resident of Kashmir. She had no known comorbids, and she had presented to us. She had presented to us with a history of cough and recurrent pneumonias in past 2 years. Also complained of pain in neck and right upper chest for past 1 year, and had difficulty in swallowing, so much so that grade 4 when she presented to our clinic, and had a documented weight loss of 9 kgs. When she presented to our clinic, she had worsening difficulty in breathing over a period of 1 month, such that she was even able to walk. She was not even able to walk short distances and had orthopnea as well. And she reported a history of multiple hospitalizations for pneumonia, for which she received supportive care only and IV antibiotics. She reported no history of prolonged GERD, underwent upper GI endoscopy twice, no other surgical interventions were reported. She denied any history of cancers in the family, no history of tobacco, betel nut ingestion, or alcohol. So on examination, the significant findings were she had tachypnea and a saturation of 92% on room air, an emaciated young female with significant labored breathing and hoarseness of voice. She looked pale and dehydrated, had dilated neck veins and supraclavicular swelling on the left side. No lymph nodes were noted, and on chest examination, she had significant intercostals and supraclavicular recessions, stridor, expiratory stridor, and there was a bronchial breathing on the right side and harsh vesicular sounds on the right side. So moving on to the investigations, she had undergone CD chest, which showed significant proximal esophageal luminal dilatation and soft tissue density in the posterior mediastinum with asymmetrical circumferential mural thickening. On the CT scan, as you can appreciate on the picture on your left, there was complete effacement of the esophageal lumen, along with the compression effects on the trachea. The mass was extending from the from the cervical and upper to mid-thoracic esophagus, extending up to the subcarinal regions, and it was measured as 10 into 5 into 6 centimeters. So she had upper GI endoscopy and which proved to have upper cervical growth, and the scope could not be negotiated. Unfortunately, the biopsy that were taken at that time was inconclusive. So she had to go and she had to undergo another endoscopy, which showed the similar findings, that is the mass just below the upper esophageal sphincter. And again, it was the lumen was completely effaced and the scope was not negotiated. Diagnostic challenges here are such tumors like schwannomas. They are mostly asymptomatic and cannot be diagnosed on clinical or radiographic basis alone. Histology is essential for diagnosis, and an endoscopic guided fine needle aspiration biopsy is the modality of choice. But unfortunately, it's unavailable here. So So the biopsy report showed spindle-shaped cells. The presentation is not showing here. It's not showing here. So basically, it was showing the spindle-shaped cells, and it was positive for S100, which is a pathognomic for the schwannomas. Moving on to the intervention, when she presented to us and got admitted on her first post-admission day, she was shifted to ICU as a result of severe respiratory distress. And after obtaining general anesthesia fitness, and only the significant findings were that she had an HB of 9.6 and ESR and CRP were raised. So a surgical plan was made. After a high-risk consent was taken, a multidisciplinary team discussion was done, and an early intervention was planned. So the decision was whether to go for enucleation or esophagectomy. Due to the giant tumor size, and as there's no role of chemoradiotherapy, and the high suspicion of malignant transformation is there in such large tumors, so we decided to go for esophagectomy. On her fourth post-admission day, she was shifted to OR for 3-stage esophagectomy. General anesthesia was obtained using double lumen endobronchial tube and under the FODL, since the intubation was difficult. NG tube was passed, preoperative antibiotic was given, and upper midline laparotomy and cervical incisions were given, and 2 teams were working simultaneously on both the sides. In laparotomy, it was checked for the metastasis, gastric conduit was made, saving the right gastroepiploic artery. Cocker maneuver was done to achieve the adequate length, and feeding jejunostomy was made for nutritional support. In the cervical region, dissection was performed medial to the carotid sheath and lateral to the strap muscles. Then dense adhesions were noted in that site, and they were taken down. Smooth to firm hard mass was protruding from the wall and going upwards to the thoracic outlet. In posterior lateral right thoracotomy, we reached the cavity through the 5th intercostal space, and the following findings were noted. So as you can see, the pleura is intact, and dilated azygous vein was noted. There was a large mass in the posterior mediastinum, and it was compressing the right main bronchus. After the opening of the mediastinal pleura, there was a polypoidal vascularized mass. So after the excision, as you can appreciate on the top of the picture, the proximal cervical edge, it's completely occupied by the mass, and the distal esophagus with the gastroesophageal junction. So a subtotal esophagectomy was done, hemostasis was secured, chest tube inserted, and a cervical esophagogastrostomy was made. Post-operative course, she was weaned off the ventilator on the first post-operative day, stepped down to the ward on the second, and her feeding was started via jejunostomy. On third POD, she had her chest tube removed. NG tube was removed on the 4th day, and we started her orally on the 5th post-operative day. On the 7th post-operative day, she had esophagogram which showed no leaks, and she was discharged to home. So the significant improvement in respiratory rate and pattern was noted. Swallowing for both solids and liquids was reestablished. Feeding jejunostomy was removed on the first month follow-up, and she remained well throughout 6-month post-operative periods. Hence, the decision to perform a definitive procedure proved to be a life-saving in a case of young female who came to us in such distress, and we did not stage the treatment. Post-operative histopathology was in favor of benign schwannoma. The proximal margin was 1 centimeter away since it was so high up, but it was tumor-free, and distal margins were 8 centimeter along with the adventitial margins were 0.1 centimeters away. 7 lymph nodes were recruited, which were all benign. So we looked for some relevant literature, and I came across these few cases. In the 2022, esophageal schwannoma was reported by Nishad et al. And they also reported that the differential diagnosis of subepithelial tumors, gastrointestinal tumors, esophageal schwannomas should be kept in the differentials. And endoscopic ultrasound evaluation is gold standard for evaluating subepithelial lesions, which propose difficulty in diagnosis, but it is not available in our setting. And it also provides the edge in differentiating malignant types. Another case that was reported was they also suggested that a full thickness excision was indicated because there are dense adhesions between the tumor and the surrounding esophagus. So when there are dense adhesions and the whole thickness of the wall is involved, you cannot go for the enucleation, as it will be difficult to close the defect. In our experience, also 4 years experience, we did 119 esophagectomies, out of which only 1 was for schwannoma, the case that I'm presenting, and the rest were for squamous cell carcinoma, adenocarcinoma, and the 2 cases of leiomyoma. So the learning point from our case is the diagnosis of esophageal schwannoma is difficult. Atypical presentation may lead to ambiguity and delay in diagnosis. Like mostly with the atypical presentation, like in our case, the female also delayed. And most of our patients in esophageal masses, they try to adjust their life routines and swallowing habits according to the disease. And they do not report early in the early phase of the diseases. So therefore, benign esophageal tumors should also be kept in differentials, and as the complete excision yields good results, like in our case.
The time is up, please.
Thank you. Questions, please.
Any questions?
Dr. Solid.
My name is Solid Fatmi. I'm from AKU. Congratulations for such an amazing case, and I congratulate all of you for having a great result.
Thank
There's
you.
only one comment on this. Whenever you're doing those masses with superior vena cava syndrome, he had a superior vena cava syndrome. So you should be prepared of a lot of bleeding. So that's one comment that you should be taking care of. The second thing is, whenever you're intubating these patients, intubate them in deep sedation. Do not paralyze them. Otherwise, they will lose their airway. So those are the 2 comments, but I think you guys already took care of it. Well done.
Yes. Thank you so much.
Our next presenter is Dr. Zara Shirazi from National Institute of Cardiovascular Diseases.
Assalamu alaikum, everyone, my respected teachers and colleagues. Can you imagine being told that your heart is on the right side? How will you, what you think? That's the reality of the people who have dextrocardia along with the CHOF. I am Dr. Zara Shirazi, fellow from National Institute of Cardiovascular Diseases, presenting you the case, the heart that beats to the right. It's a fascinating case of dextrocardia and situs inversus with tetralogy of Fallot in a 23 years old female. Yes, Your Honor. Ah. I'm sorry for the inconvenience, please. Okay. No, please step in. Next. Okay, next, please. Disclosure, I have no financial interest, arrangement, or affiliation that would constitute a conflict of interest. Next. Tetralogy of Fallot is a commonly identified cyanotic heart disease. We all know about it, but its affiliation with dextrocardia and situs inversus is a rare entity. That is our case. Next, please. We describe a case of dextrocardia and situs inversus in a 23 years old female. She presented to us when she was 23 years old for the total correction. But let me tell you about it, that at the age of 17 years, she was diagnosed with this disease and her central shunt was done. We did the total surgical correction with magnificent outcomes. Next, please. Let me tell you the history of my patient. In 2017, she was diagnosed with dextrocardia and situs inversus. A central shunt was done. And then in the year 2020, she came for total surgical correction. Throughout her life, she had experienced decreasing exercise tolerance, frequent episodes of cyanosis, and substantial shortness of breath upon exertion. Please, next. On physical examination, my patient, 23 years old female, she had a body weight of 30 kgs and a height of 150 centimeters. If we talk about the blood pressures, she had 102 by 70 millimeter mercury and heart rate of 89 beats per minute. She had saturation at that time, 89% on bromure. On physical examination, there was cyanosis, which was central and grade 2 clubbing and scleral hyperemia. Result of the pulmonary exam was normal and there was no organomegaly noted. Please, next. Here, let me talk about the investigations, what we did. First of all, electrocardiogram. If you can see that this is an ideal ECG for a dextrocardic patient. For our knowledge, I want to tell about the dextrocardia ECG. We can see in the first lead one, there is negative deflection of the PE, QRS, and the T wave. And we can also see that in the chest leads, there is no R wave progression. So this is an ideal ECG of dextrocardic patients. Please, next. Here is the chest X-ray of my patient, which showed the apex of the heart on the right side. We can see that the gas bubble in the stomach is also on the right side. This shows my patient is a situs inversus. The heart parameters were within normal ranges. Next, please. Now let me talk about echocardiogram. My patient had a VSG of 20 mm with obstruction of RVOT and overriding of aorta. 12 millimeter was the diameter of the pulmonary valvular annulus, and sizes of the left and the right PAs were 9.5 and 10 respectively. RV systolic and diastolic mild dysfunction was there. If we talk about the Z-scoring of my patient, then main pulmonary artery, RPA and LPA, minus 4.53, minus 1.38, and minus 0.85 respectively. Next, please. There were no significant collaterals were present, and the shunt was right to left, and the good thing was there was a central shunt that was functioning. CT scan was a necessity because we had a concern. We were doing the redo sternotomy. Previously, central shunt was done, so we had concern about how to proceed, how to go, how to do the cannulation and other things. So we did the CT scan. Next, please. So we planned, after all the investigations and CT scans, for the sternal approach. General anesthesia was given, median sternotomy was given, and systemic heparinization. My surgeon was on the left side once adhesionolysis was completed. This was the change, obviously, in our patient. Aortic and SVC cannulation was done from the right side. And after partially decompressing the heart, the IVC was cannulated from the left side. After establishing the cardiopulmonary bypass and aortic cross-clamping, after the cardioplegic arrest, we ligated and divided the shunt. VSG closure was done with the use of the bovine patch. Next, please. Let's talk about the RVOT reconstruction. Then approach was combined, that was both from the transatrial and transpulmonary, to reconstruct the RVOT musculature and the RVOT tract. RVOT obstruction was relieved with the use of a transannular patch, and the monocuss was applied as well. After de-airing, weaning from the bypass, putting the drains, and coming off, let me tell you, the 109 minutes was the cardiopulmonary bypass time, and 84 minutes aortic cross-clamp time. After uneventful bypass, PA pressures were 17 millimeter of mercury. Here is the post-op X-ray of my patient. There were no events in the post-operative period, and my patient got discharged on 6th post-operative day. Before discharge, echocardiogram was done, which showed the complete closure of the VSG. There was no remnant shunting, no RVOT obstruction, and mild RV dysfunction, and there was no pulmonary regurgitation. Next, please. So, is the most common, you can say, cyanotic congenital heart disease, and it is one of the surgeries that cardiac surgeons have done in the initial years. Advances in the diagnosis, perioperative, surgical, and the postoperative care have been such that CHOF is now expected to survive in the late years as well. Next, please. Little bit, let me talk about the literature. In 1952, Scragg and Denny described this combination, and there were very few. There was a study of 147 TOF patients, and in those, only 2 were the patients who were dextrocardic. There was another study of 63 patients who were dextrocardic, but there was 1.6% of situs inversus and CHOF. We can say that's a very rare entity, and National Institute of Cardiovascular Disease is blessed that we have such type of patients. Next, please. I want to tell a little bit about, in the last decade, surgical rectifying was mostly done in 2 ways. Initially, palliative, systemic to pulmonary shunt, and then repair. But I want to tell you all that nowadays, if a symptoms appear in a baby of around 3 to 6 months or earlier, single stage repair is proposed. Next, please. Now, let's discuss about the challenges we faced. Obviously, the redo surgery, redo stenotomy, and then afterwards, altered anatomical location and orientation of the heart. Visualization of the VSG was the problem, and not just visualization, we had to do the closure as well. Relief of the RVOT obstruction, and this atypical arrangement may make it more difficult to repair. And there is what we know, what we have a fear. We have a fear of risk of residual VSG as well as RVOT obstruction. And don't forget about the damage to the conduction system. But our patients had nothing like that. The surgeon approached the VSG at a different angle in a patient with dextrocardia. And there is obviously high probability of heart block, but fortunately, it was not in our case. Surgeon's technique obviously is a choice of matter. And transatrial and transpulmonary approach is a preferred technique these days. So let me conclude. In conclusion, preoperative planning, careful assessment of the patient's anatomy and physiology, and close collaboration among the team member that is very, very necessary are the key roles to address these challenges effectively and achieving successful outcomes. However, our patient has an excellent post-op outcome and follow-up profile. Thorough physical examination of newborns and a screening echo in the early life may aid in detecting the diagnosis early. Here are some of the references.
10 minutes.
Yes. Next. Acknowledgement. Thank you to my teachers. Next. Thank you.
Dr. Ghufran, cardiac surgeon. I have a small question. What was the reason for choosing the central shunt? Is it because of the arrangement of the PA and the aortic branches? And how did you do it? Whether you use some conduit or just joint PA with the aorta? Was it Davidson shunt or some other kind of Patterson or Potts?
I request Dr. Iqbal to please comment on this.
Actually, this case was done somewhere in 2017. So exactly, and the record data was not available about the patient status at the time of presentation when the central shunt was done. But probably, I think the patient must be in the refractory scale, intubated and shifted from the pediatric cardiology. So as a rescue manner, we have just gone in and did the central shunt through conduit aorta to MPA. That is my understanding. Exactly, we don't have a record of the reasoning about central shunt.
There are certain patients who are very sick patients with a hemoglobin of say 23, 22, 23, hematocrit around 70, and having repeated cyanotic spells. So these are the ones where we always thought that doing a total correction at that time has higher morbidity as well as mortality. So as a policy, we used to perform a shunt, wait for 6 months, they would come back, some of the collaterals would settle down, they would have a better hemoglobin, so better blood coagulation factors, and then we would close the shunt and perform a total correction. This could be one of those cases. But as you rightly said, that we don't know in which condition patient was brought to the hospital for first surgery. But coming from far off areas, then some of them had very poor nutritional status. So all these things would settle down. Now you have seen patient was not all that bad. Her hemoglobin was 16 or 15.
Yes, sir.
So it was because of the shunt. Only problem was that she was lost to follow for next 6 years. She should have come after 1 year or so that we could perform better a second operation. This could be one of those cases.
Maybe.
So just one comment. I mean, these patients, they are good patients. They are adult individuals, but have congenital malformations. Most of their treating surgeons and pediatricians, they are in a pediatric ward, pediatric ICUs, but they cannot be admitted in pediatric wards. They have to be nursed in adult wards. They are special people. They have got their inherent special issues. So there was, as we are developing pediatric surgery, these patients will require subsequent surgeries. So Texas Heart was the first institute in this world to recognize their specific problems. And they have created another department, a Gooch department. I think sometime down the line in this country, we might also have to create a special department, another subspecialty to deal with Gooch patients with their specific needs and specific requirements. Thank you very much.
I have a question. Can everybody hear me? Is it working now? Can you hear me?
Yes, sir.
Oh. So thank you,
Dr. Shirazi.
Zara Shirazi, for your presentation.
Thank you, sir.
It's always nice to have a presentation which is unique and rare. And the results, have been very, very encouraging. A couple of things which I find a little difficult to understand. One was, and the question has been asked, but it has not been answered correctly. Okay, why at a 17-year-old should you do a PT shunt or a central shunt of any kind? There is what evidence is there in literature which supports the notion of higher hemoglobin resulting in higher mortality? Those are the notions of the 1960s and 1970s. Lately, this doesn't hold true. But obviously, those are also, we have to look at it from a point of view that most of the data is coming from the Western literature, and they have got younger patients than ours. The third thing is that in your repair, you have used a monocusp, right? And in an adult patient, who had a preoperative pulmonary artery pressure of 80.
Yes.
Yeah. So these are patients who are going to have significant pulmonary regurgitation with right ventricular dilatation and dysfunction and arrhythmias. Why was the decision not made? What was the reason why you all did not use a tissue valve in the pulmonary position, which would have prevented all these complications?
Sir, at that time, it was for the best interest of the patient to do the monocus, I think. But as that's another option, sir, we could have done this.
Actually, the pressure of 80 was across the infundibulum, not the PA pressure or something like an 80. That is not a pulmonary hypertension. And regarding the use of the bioprosthetic valve instead of using the monocus, in my opinion, maybe the surgeon's choice. And most of the time in grown-up patients, like present 15, 16, we go for the either because they have native some gradient also present and they're not routine. In NIS we did it, we are changing the bioprosthetic valve. And the second thing in 2017, I don't know, but we are not using in this type of, but I agree with you. I agree the bioprosthetic valve was much better. They have prolonged durability. They avoid the PR in the long term, but then again, they are prone for maybe require redo surgery in the age of 40s, 50s. Percutaneous. 17.
1/7 tha na, gradient at the RVOT level. So if it is that low, these are bound to develop RV dilatation and pulmonary regurgitation very early on. So if you are not using a mechanical, a valve, a competent valve, and in creating a monocus, then the advice is to leave a gradient of about 40. Only when you're using a competent valve, do you go down on your gradient to about 20. Right?
I agree with you.
So these are just things which we
I
can
agree
learn.
with you.
And I would agree with, I'm sure you from PNS Shifa, Nasir, that we need to develop a interest group which go down, which are going to take care of the adult congenital heart disease patients. Varis is here. Yeah.
Thank you very much. Very fascinating presentation. Number one, yes, we do see sometimes these patients with heart somewhere else, actually dextrocardia. And there is heterotaxy syndrome associated with that as well. So we need to be very careful for which patient you would choose to go ahead and which not. So this patient was basically slightly older. If she was younger child, I would always reassess for this patient for heterotaxy and would I do it or not. Secondly, as Dr. Munir said, that was my thing actually, that if you do a monocusp, we all know that when we do a monocusp, this monocusp gets you just about out of the hospital. So as soon as this patient leaves the hospital, the monocusp tends to stick to the transannular patch that you've done. So you have two problems here. Number one, this monocusp is going to become dysfunctional, number one, very quickly. This patient has had a sternotomy before, and now you've done a second sternotomy. And obviously, there is only as much of the aorta that you're going to be cannulating the third time if you come back. So treatment of choice, especially with a gradient that you have achieved, which is very nice that you have come down to like 17. If the gradient was 23, 25, or 40, then would have been different because your right ventricle would have been preserved. But if your gradient is less, it means that very, very quickly this RV is going to get dysfunctional actually. And then you'd be talking about either putting in a transcatheter melody valve in there, which people do in the West, or you're going to reoperate on this patient again. So far in Pakistan, I think 3 or 4 melodies have been put actually. And maybe down the line in 10 years time, there would be expertise in the Gooch capacity that we would be able to do that. But I think putting in a tissue valve would have been a better choice. But very well done. Thank you.
I agree with you about the tissue wall, and it is a better choice. The grown-up patient and tissue wall provide more better protection for longer period of time with the avoidance of pulmonary regurgitation. I agree with you. Regarding the Gooch, we are evolving, and as the time passes, things gets more evolved, and especially in the government setups, somewhat we are more slower than the private setups to develop but the rooms are open for the improvement. The question that I asked with you about, Professor Arif said about the polycythemia or something like a low platelet count or something like a prolonged INR in this type of patient, and proceeding for the whether to go for the shunt or whether to go for the total correction. Though stage procedure quite mentioned from the long time, and gradually its scope is limiting more and more. So what we think, whether should we go for these patients if the patient has a good pulmonary sizes, but present refractory still very much polycythemic, like 23, 25, or low platelet count. So is there any studies are done to compare these population about the outcome?
There are.
Sir, can you hold mic, please?
There are studies, 2005, 2006, which have looked into this possibility of polycythemia being a risk factor. So it is shown that it is not anymore. It is not a risk factor. So your risk remains the same, whatever your polycythemia is. The polycythemia is because of increase in RVOT obstruction, right? And the more hypoxic you get, the more polycythemia you get. So, but the risk of a BT shunt is the same as you do for with a total correction.
So the thing is,
because you do not just look at the BT shunt operative mortality, you look at the interval mortality also. So you have a long period of wait, and in that period there are people or patients who will die, and they do die. So it is better to do venesection, get the polycythemia down to a level that you are comfortable with. Agar wo 24, 25 hai, to get it down to maybe 21, and you can.
Is by Ahmad from Liaquat National Hospital.
Yeah. Assalamu alaikum. My name is Dr. Shehzad from Liaquat National Hospital. On behalf of my cardiac surgery team, I'm going to present a unique case. Open kar deenge? I'm going to present a unique case, which is man proposes, God disposes. So why I did choose this title for my case? Because as far we know, human can make plan, but ultimately the outcome is determined by Almighty God. Let's start the case with a scientific fact that blunt chest trauma commonly results in injury to the right side of the heart and the aorta. So I present a case of an 18-year-old Afghan male patient referred to us with a bullet injury to the left side of the chest for mitral valve replacement due to severe MR. Initially, patient admitted under chest medicine ward with complaints of shortness of breath on exertion and history of gunshot injury to left side of the chest treated with chest tube drainage, and about 200, 300 ml of hemorrhagic fluid was evacuated. As you are seeing in the picture, the entry wound below the left nipple and the exit wound was 3 inches above the entry wound. And on examination, there was harsh thrill was present below the left nipple. Admission chest X-ray and CT scan was suggestive of ARDS and pneumonia. And the CT scan of the same patient showed bilateral proliferation on maximum was moderate to severe was on left side, which was already evacuated, and minimal on right side. There was patchy areas of infiltrates are seen in the perihilar region, which was more on right side, and findings were more suggestive of ARDS or pulmonary edema. There was cardiomegaly also. On echocardiogram, severe MR and moderate TR was noted. Then the diagnosis of severe MR with moderate TR was made and patient was referred to cardiac surgery department for further management. Patient taken to the OR for valve replacement surgery after all pre-op assessment and investigations. And the operative findings were there was no hemopericardium and the aneurysm of 2 into 2 centimeter close to the apex, 1 inch to the left side of the left anterior descending artery was present. And harsh thrill was palpable on the aneurysmal area. LAD was appeared intact and palpation of left atrium confirmed severe MR and the anterior mitral leaflet was found to be torn and detached from the annulus. And this is the video, heart lifted and the aneurysm showed by our cardiac surgeon. The aneurysmal area was incised parallel to the LAD and a defect of 1 into 1 centimeter in the anterior septum was identified. The defect closed with patch. The VST was closed with a bovine patch, partially with interrupted plagiated sutures and partially with a continuous technique, and the left ventricle was closed in the standard manner. The left atrium was opened, the anterior mitral leaflet was torn in the middle and the detached from the annulus. This was excised, and a size of 29 Hancock tissue valve was implanted. Post-operatively, recovery was uneventful and the patient was followed up in OPD regularly, and post-operative echo showed no residual VST. Discussion. The right ventricle and the aorta are the most commonly affected sites after gunshot injury to chest, followed by the left ventricle. The mechanism by which ventricular septal rupture can occur due to trauma is laceration of septum after decelerating force and the cardiac contusion between the sternum and the spine. Due to close proximity of the coronary arteries to the chest wall, they are more vulnerable to direct trauma, which may result in acute coronary thrombosis. Conclusion of my case is blunt chest trauma commonly results in injury to the right side of the heart and the tricuspid valve and aorta. An echocardiogram may not be completely reliable. So a cardiac CT scan should be done in all gunshot patients if this facility is available at your setup. Thanks for your attention. Any question?
So the patient was 18 years old. Why did you choose for the bioprosthetic valve? Was there any reason?
Yes, family was counseled about the both conditions of tissue valve and mechanical valve, and this was their decision to go for tissue valve because they have no facility of any lab INR facility in their remote areas in Afghanistan.
I would like to add one thing. Nowadays, cog check machine is there, and mobile services are everywhere. It's available in the WhatsApp and everything. I think 18 years old, if it would have better, he would have gone for a mechanical valve rather than a tissue. I understand they don't have the laboratory and other things, but again, I would say 18 years old. I think the longevity of tissue valve hardly would be 10 years, 12 years, particularly if they are coming from the Afghanistan. And what do you think? Will they be able to come again for a redo surgery, because the cardiac surgery is not widely available over there as well? So I think next time this should be, I would welcome the opinions from other people as well.
I am Dr. Furqan from NICUD. One question is that it's a very good operation. I think whatever that surgeon thought at that time, he did it. If he thought that tissue wall is available or it's. My question is that how bad was the detachment of the anterior leaflet? Was it repairable or not?
Anterior leaflet?
Anterior leaflet detached from the mitral annulus. How bad that was? was it repairable or unrepairable?
It was repaired with pledgeted sutures and bovine patch. All
But you said that you replaced the mitral valve. I'm asking
no,
about
no,
the
it was
mitral-
not. It was not repaired. It was torn.
It's totally torn.
Yeah.
Okay, that's fine.
Injury to the heart, which was formation of VSD and detachment of the leaflet, mitral leaflet. This was because of, say, velocity of the bullet, blunt trauma.
Yeah.
It was not actually actual trauma, but it was
gunshot injury.
Yeah, because the wound of entry and wound of exit were very close to each other. So probably the bullet went in and came out, but it caused blunt trauma or to the heart, because of which VSD was formed and septum, one of the leaflets of mitral valve was detached. And aneurysm was formed probably because of damage to the muscle wall as well, LV muscle wall.
Yes.
And one other comment is that you did an echocardiogram, but I think the VSD was not detected on echocardiogram. Only the rupture, only mitral regurgitation was detected.
This was the reason we presented this case, because sometime echocardiogram couldn't pick the aneurysm area. That's why CT cardiac should be done in all cases.
Yeah. Thank you.
I am Dr. Sadawan. It's very nice case, but what I have learned with time, that surprises in the operation theater, they are really difficult to manage, and sometimes you come out with a bad outcome with them. So it's always better that pre-operatively you should always know that what you are going to find in your surgery, and there should not be surprises, and you should be very well prepared for everything that you are going to do. That will really make difference. So I think echocardiography or a clinical examination both may have diagnosed VSR and also the aneurysm as well. And maybe at that time you have ordered for the CT, and you may have known it better before going to surgery. That would be a better strategy, I think.
Thanks for your suggestion, sir. We will consider next time, inshallah.
Okay, so Shahzad, nicely presented and a very interesting case, and Kaisar, well done. Still, the reason people are asking the question is because there is some concern, right? And having an MDT, but with an investigation that you have all had, I did not see a transesophageal echo as part of your investigation.
It was not.
Transesophageal echo will give you the best information regarding the mitral valve. And for every mitral regurgitation, I think it should be a practice of every one of us that we need to have a pre-operative or per-operative TEE, so that you can actually assess the mitral valve. And this case, you sometimes the surgeon goes with a pre-planned plan of what to do, and they don't change it. But if a TE had been done, maybe the mitral valve injury might have been such that it could be repaired. If the chordae and the papillary muscle are intact, then you can do patch repairs and resuspension and all that. This was not an acute case. It was a chronic case.
Yeah.
It had been, so it was not that he was hemodynamically unstable and he had to do a very rapid operation. So just a consideration for anyone who has next time a gunshot injury and survives, that a TEE would have given you better, and also the transesophageal would have given you a better look at the VSD as well.
Okay, thank you. We will consider it, inshallah.
I have a suggestion and a comment also. You were talking, when you were describing the wound, there is a suggestion to my colleagues and to my trainees especially, that whenever you are describing a wound, especially gunshot wound, then you will never say this is entry and this is exit. Because you were not present at the time of, the incidents, and you can't make comment that this is entry and this is exit, because in your case, it was a chronic case. And at that time, possibly the wounds were healed and you can't say, but you have to describe there were two wounds. So you have, a broad area of thinking that what can happen. And that second thing, you were continuously telling us that you were telling about the blunt chest trauma. This was not blunt chest trauma. This was the penetrating trauma. This was a, purely gunshot injury case. And in discussion, you were saying that there are, you were telling that right ventricle and aorta, mostly they are is there any literature which is saying this, that mostly on the right side, these structures are on risk? Do you have any reference?
I didn't find any literature.
Because it's the viscera who are on the risk, it all depends upon the mechanism and the site of injury. You can't never say that in blunt chest trauma, aorta is on risk or right ventricle is on risk. It's all about the mechanism of injuries, in which you can say that, yeah, might be these areas can be injured, these viscera can be injured. But if there is no literature, then I don't think so that you can say that in blunt chest trauma, the aorta or right ventricle is at risk. Thank you.
Okay.
Just a comment. You put on your last slide that on every traumatic injury, there should be a CT done. Actually, I would say that's a take-home message that you're giving to people. What I would suggest is what Munir said exactly, is when you have a problem, this patient, we know then patient become very unstable if they have got a VSR, or the patient becomes very unstable when they have got a ruptured chordae, basically. And the ruptured chordae or the mitral regurgitation, when that happens, patients are way more sicker than the VSR. So you were lucky that the patient was not in that zone. I would suggest that if I was to conclude it, I would say that transesophageal echocardiography would be the gold standard before you go into the theater, knowing exactly that you've got a VSD, which would be shown on your TOE. And also it would give you the mechanism of how and where the mitral valve is torn and if it can be repaired or not.
Okay, thank you, sir. We will consider it.
I have one question. My name is Dr. Vikram. I have to ask about the mechanism of injury. So you said about the entry and exit point. So was that the speed of that bullet that was causing injury and VSR or something else?
Please repeat the last line.
Was there a speed of bullet that was causing that injury and VSR and mitral regurgitation or something else?
Please, I will take help from my senior.
Thank you. I'm sorry I was not there when this surgery was done, but I can only presume that this is what happened. It's basically a sort of a shockwave injury rather than anything else. Because from the details that we just learned, the pericardium, there was no pericardial effusion. So there was no penetration of the pericardium, basically. Okay. So it was more of a shockwave injury that caused these problems. Now, we don't know the condition of the patient and at what angle the bullet went in and whether it struck something, it ricocheted off bone and came out 3 inches away from the entry wound, whichever was the entry or exit wounds. But there was, as the doctor mentioned, there was there was blood in the pleura on both sides, more on the left side. So it's quite possible that the bullet struck bone and took another direction and came out. But it is basically the shock wave that creates the injury. So there was no penetration of the heart. There was no penetration of the pericardium. But obviously, the shock waves did whatever damage that was done. And in these cases, obviously, if the anterior mitral leaflet is torn off the base, then it's a sort of an acute situation with acute MR. So then, and if obviously a VSR is created at that time, so we have two shunt, basically a shunt and a defect with acute in an acute condition. So doing a transesophageal echo in a patient who might be dying, I think the best thing to do is, as one would do a transesophageal echo, see what diagnosis you have. And obviously, one would not expect a VSR in this condition, but an acute mitral regurgitation needs to be fixed, and I'm sure that was done at that time.
Very right, sir. Thank you very much. I think we are
Thank you so
running
much.
out of time.
Thank you, Dr. Shahzad. Now I would like to call Dr. Asibur Rahman from Aga Khan University Hospital for his case.
नहीं मुझे अगर appointment खाना हो तो मैं तो दिखा सकता हूँ। हाँ? इस पे नहीं दिखा सकता, इससे नहीं, इस पे नहीं।
Assalamu alaikum. Thank you. Good afternoon and assalamu alaikum. So I'll be presenting an interesting case with the title, The Hunch and the Murphy's Law. I have nothing to disclose. So this was a case of a 10-year-old boy who presented to us with history of recently diagnosed B-cell acute lymphoblastic leukemia, for which he received induction chemotherapy 2 months back, after which he was termed disease-free. Post-chemotherapy, he had issues of febrile neutropenia, of which he had several episodes in last 1 month, and he was admitted in hospital several times. The blood cultures that were done showed MRSA in the blood, and he was treated with oral antibiotics and IV antibiotics for this. It's not changing here. Okay. So on examination, the child was cachectic. Okay. There was no murmur on auscultation, and rest of the examination was within normal limits. So on investigations, there was mild anemia with a hemoglobin of 8, and the CRP was slightly raised up to 32, while ECG showed T-wave inversions in the lateral leads, which indicated ischemia. Echo was done, attached to the LA roof, the aorta, and the pulmonary artery. Excuse me. So this was the short axis view, in which we can see that the mass was compressing the left main coronary artery. And this was an extra cardiac mass because it was compressing the left main coronary artery. So this was the CT angiogram that was done. And as you can see, as we come down from the PAs, there's a mass which is not enhancing and it's compressing the left main coronary artery. And this was the arterial phase of the CT scan. When this was observed in the venous phase, there was a delayed enhancement in the mass, which indicated that there was contrast uptake in the venous phase. So that raised a possibility of a vascular malformation. Okay, so as there was suspicion of vascular malformation, so we did an ultrasound because we did not find any feeding vessel into this mass on the echo. So the ultrasound showed that it was a solid mass and raised a suspicion that this could be an aneurysmal sac that is filled with clots. Okay. So now this was our hunch that either this could be a recurrence of lymphoma, which was the diagnosis from the referring hospital. Basically, he was referred from an outside hospital to our hospital, which was unlikely given the location of the mass, which was intrapericardial. The other hunch of ours was this could be a coronary artery aneurysm, as we had found delayed venous enhancement on the CT scan. So we went in for an urgent surgery as there was ischemic changes on the ECG. We did a median sternotomy with a cardiopulmonary bypass on standby in the operating theater. After pericardiotomy, we saw that the pericardium was thickened with fibrinous adhesions. There was a large mass seen 3 into 3 centimeters attached to the pulmonary artery left laterally. As we were trying to see the extent of the mass and manipulating the mass, the patient became hemodynamically unstable and he was hypotensive. We had to start him on inotropic support. And in spite of high inotropic support, we were not able to maintain effective blood pressures. Also, there were ischemic changes on the ECGs. So we put the patient in the Trendelenburg position, gave emergency heparin, did an aortoatrial cannulation, and went on an emergency cardiopulmonary bypass. So as we were on bypass, we opened the mass in order to relieve the pressure on the left main coronary artery. And we saw that the mass was filled with clots. We were gently removing the clots as we saw the brisk bleeder from left main coronary artery, which was confirmed by putting in a probe in that, and it was going into the LAD and left circumflex artery. So at this point of time, we realized that this was a coronary artery aneurysm that basically, and that was the defect in the left main coronary artery was patched with a bovine pericardial patch. As you can see, the patch is sitting on the left main coronary artery as a hood. And this was done using the white sutureless repair technique. And once this was done, the ST is normalized. So once we had done this, the aneurysmal sac was still there, which was filled with clots. We started removing the clots and we were advancing towards the transverse sinus. And as we reached the base of that aneurysmal sac, we noticed another 2.5 centimeter defect, which was basically a defect in the roof of the LA. So we had the patient head down. We were on cardiopulmonary bypass. We asked the perfusionist to keep the heart slightly filled, and with minimal suctioning on the in the LA, we repaired the defect in the roof of the LA with a bovine pericardial patch. So once that was repaired, the clots excised. So this was the aneurysmal sac that we were left with. As you can see here in this video, patient was smoothly weaned off with the cardiopulmonary bypass and a tedious hemostasis was done. And we came off and into the CICU. Post-operatively on the next morning, he had no neurological deficits. He was moving all 4 limbs. So he was weaned and extubated. He was ambulated out of bed. There was no neurological deficit. On second post-operative day, this patient develops mild left-sided weakness, for which an MRI was done, which showed acute ischemic stroke in the frontal region. And also there was evidence of old infarcts in the frontal and temporal region, indicating that he might have had previous episodes of thromboembolic events as well. This was the post-operative echo, which show that there is no, there's a short axis view, which showed no mass effect on the left main coronary artery, and there is a good flow in the left main coronary artery. Histopathology confirmed that this was an aneurysmal wall. There was no malignancy and tissue cultures are negative till date. So why we are presenting this case? The incidence of coronary artery aneurysms as reported in literature is around 1.4%. With out of them, less than 3% are due to infectious causes. Most common causes in children are due to Kawasaki's disease, which was not the case in our child, and in adults it's usually due to the atherosclerosis. So the treatment options that we had was either to do, we could have opted for coronary artery bypass grafting, which would have been a daunting task in this child who was hemodynamically unstable, cachectic, and also there are concerns regarding longevity of the grafts. While other option is to do a patch closure, which is a useful technique and has been defined in literature. Coming to the literature review, so I discussed two case reports of the first is of an adult patient who had a right coronary artery aneurysm which was repaired with a vein patch. The other is a mycotic aneurysm with a contained rupture in the left circumflex artery in a child that was also repaired with a vein patch. So in olden days, it would have been a challenging task, or this would not have been possible that to repair ASDs with beating heart without cross-clamping of aorta. But now there is literature that this is being done. And like in this study, they have compared both the conventional and without cross-clamping the aorta, and they found out that the results were not significantly different, and as well as the stroke was not significantly different between the two groups. So to conclude, this was most likely a mycotic aneurysm, likely secondary to staphylococcal infections. This was complicated with the fistula formation, as this is a common complication with staphylococcal infections. Patch closure can be a useful technique in pediatric population. Thank you.
Dr. Ghufran, I have done similar case. The one question I want to ask, doing a patch repair, that means this was a secular aneurysm. So in a fusiform aneurysm, I don't know what is the answer. I came across a case about a year ago where there was a huge aneurysm of the right coronary artery, which was arising just beyond the takeoff from the ostium, extending down to the acute margin of the heart. It was around 10 centimeters. And there was he presented with inferior wall MI, and there was a huge PDA coming from the, beyond the aneurysm. So what we did, we went in, we had to, excise the whole aneurysm and then double ligate the right coronary artery. I thought I would get away with by doing a, grafting of the PDA. The patient did come off the pump, but he started having VT. So I didn't realize what's going on. So I looked at the angiogram again, went back, looked at the angiogram, and then I realized that there was a big RV branch coming from the aneurysmal sac, which we managed to ligate by, resecting the aneurysm. What I did, we had already come off the pump, and we did that on the beating heart. We did and added another vein graft to the RV branch. The patient immediately, everything normalized and patient did well. I don't know whether this patch repair works in fusiform aneurysm or not. It's a question is open for the floor.
Dr. Hasi, very nice presentation.
Thank you.
Just one question to ask, that why you people put lymphoma in your differentials? What was the scenario? What was the, things which you think that?
So let me give you a brief prospect how this child presented to us. Basically, this child was being managed, and all this chemotherapy and all this febrile neutropenia episodes and all this was being done at an outside other hospital, one of the major hospitals in Korangi. So he was being managed there. They picked up this finding on the echo that there was some intrapericardial mass, and they were not sure at that point of time whether this is an extracardiac mass or intracardiac mass, and they thought this was some recurrence of lymphoma. So they basically referred this child to us, and this was during Eid holidays that he was referred to us. So we further worked up, and we did a echo again, and and they hadn't picked this up, delayed venous enhancement on the venous phase. They had this, the patient had the discs with them. So we ran it through and discussed with the radiologist. So we picked up this delayed venous enhancement, and that basically made us kind of more towards that this was a coronary artery aneurysm or a vascular malformation rather than any other mass.
Yes, you also showed us CT scan, and that mass, that is not at all a multilobulated mass. That is
Yeah.
the pathognomic radiological feature of lymphoma. And in all mediastinal lymphoma, you have, if you are suspecting any lymphoma in the mediastinum, intrapericardium or whatever, don't you think that you should go for a biopsy first?
In this mass, at this point of, I don't think so.
What you will do if it comes to be, lymphoma, then?
This child, first of all, had active ongoing ischemia. Like I mentioned, ECG, so we did not have any time to wait. Even like we could have considered MRI, MRA as well, but we did not have any time for this. This child needed an urgent intervention, first of all. Secondly, I don't think so biopsy would have been possible given the location of the mass. The radiologist would not have been comfortable to put in a needle in here, CT guided or whatever. In this.
And what was the detailed, complete blood picture? Did you show us?
I don't have it on the slide here, but like I told you that this child was disease-free now. So his blood picture was normal. Just he had anemia, or hemoglobin of 8. Otherwise, other things, the lab parameters were within normal limits.
Will cardiac cath will help us? Will cardiac cath will help us in differentiating whether the coronary?
Yes, cardiac cath could have been a useful option, but like I told you, this child had an ongoing ischemia, so we did not want to wait.
Differentiate whether the coronary aneurysm or some.
Yeah, cardiac cath might have helped, but on echo, we were not finding any feeding vessel into this aneurysm or the mass. So basically this mass was clot off with due to the clots, and there was no active flow in that. And somewhere during this time, this had formed a fistula with the left atrium.
If they had a fistula, it was not picked up during the CT angio.
No, that was not picked up. There was no communication. That mass appeared solid on CT scan, and also on the ultrasound that we did, they reported a solid mass. There was no flow in that.
Is it possible the iatrogenic injury of LA during dissection of the mass?
No, sir. No, sir. We were very careful and gentle with removing the clots, and it was a punched out defect. And as we evacuated a clot that was sitting right at the roof of the LA, we noticed this defect. So I don't think so that was an iatrogenic injury.
Just last few words about the sutureless repair.
So the sutureless repair was done in a similar fashion like we do for TAPVR. So we basically did not take stitches from the coronary artery. We took it from the epicardial tissue around it and placed a patch.
Epicardial tissue with the, okay, you place the bovine graft.
Bovine pericardial patch.
And then keep it below the tear of the.
Sorry?
Keep it below the tear, a laceration of whatever opening of the coronary.
Okay.
And then how you have attach it with them.
Sorry?
Now, how you place the sutures to so that the vessel lumen will be included in the. I mean, how do you did the sutureless?
What was the procedure for sutureless?
So sutureless, the reason we are calling it sutureless is because we haven't taken the bites from the coronary artery. We have placed a patch over as a hood over the defect while taking the sutures from the pericardial. So this is a similar technique that we use in total enriched pulmonary venous return, in which we take we just take the sutures from the pericardium. We do not take the.
And then we take it from the LA valve, I mean, not directly from the confluent. Distant
Yeah,
from confluent.
yes.
So the confluent comes within the.
Yes,
page.
like we do it.
Well,
Okay.
the tissues around this actually, in the artery around the aneurysm, they are so thin and friable that even if you attempt to take any stitches, it would simply cut through. And this is a danger area. If you cut through left vein stem, it is simple a table death. So it is recommended to take a sutureless sort of a suture. If you take a subsequent angiogram, it may appear like a localized aneurysm of that artery, but still the patient is above the ground.
Yes, so that's why exactly you're rightly said, because the tissue is so friable due to the aneurysm that it's not advisable to take. And it has been described in the literature in the case reports as well that it was not possible. Like the case reports I mentioned in the right coronary artery, the tissue was so friable that they had to resect extra anterior wall of the right coronary artery in order to perform that patch repair.
Fantastic presentation, Asif, as usual. Just one comment and one question. The comment, or maybe it's a continuation of a question, the one that Gufran asked as to whether you can do a on-lay patch and what is the experience. I think from this all audience, maybe 3 or 4 people might have done a aortic, LA, left atrial, left coronary artery aneurysm repair. Yeah, they're very, very rare. So I don't know whether you can make a conclusion as to you should do a patch repair or do a graft or whatever. But if the length of the patch is something to be considered, then in my own understanding that you all do a very long endarterectomy of the LAD and you have a long venous patch and that works. So maybe in the fistulous region also, it might work. A long patch should not be a thing that should not be considered. You mentioned, so that's concluding what Gufran was asking about. What you mentioned something about doing ASD repairs without cross clamp, right?
Yeah.
And the incidence of stroke is the same if you do it on clamp and off clamp, which is very hard to digest. So maybe there is something I am missing, which needs to be clarified.
So, sir, the paper that I shared was basically, this was a paper from Thailand. They had compared 2 groups in which one they repaired the ASDs with the conventional cross-clamping technique. The other group they repaired without cross-clamping, keeping the LA full without minimal section, keeping the head down. And there was 71 patients in one group and 63 in the other. So they concluded that the results were comparable and there was no significant risk of stroke involved in the patients who underwent without cross-clamping the aorta. Yes, this is Dr. Varis, I think, wants to add something.
Do you want to say something from the dais and then I'll add something actually?
No, actually continue. I wanted to say.
So 2 things. Hasib, first of all, I know you're my resident, but I have to say this has been presented very nicely. Number 1, and everybody would agree that the questions, the way you have handled the question is very nice. If I was the judge, I would judge you on 2 things, how you presented and how you handled the question. So let me just tell you the background of what happened basically. Why did I call it the Murphy's Law? So in the UK and Ireland, there are certain sayings basically, and one of them is the Murphy's Law. So this patient was referred from oncology group from a different hospital with a mediastinal mass for resection, as this child was in another hospital. In our hospital, from our experience, we take these mediastinal mass children not in the ward, but actually in our ICU. So this kid came to the ICU, and that was, I would say, kind of a blessing to start with. And we had him on the monitor, and we could, once he came in, we could see that this child was having lateral lead ECG changes actually. So we did multiple ECGs, got our cardiology to have a look at that. And this was like 5 days Eid holidays this year, just to make things even more complex. So I had to, when I had a look at the CT scan and the way I have been trained for the CT scan and the echo, my boss would not let me look at the report actually. So he would make me see the scans. And when I saw the scan, I rang the radiologist and I said, I have a hunch that this is not what is being sold. So वो कहते हैं जिसको कि वो भेजा था खरबूजा वो निकल आया तरबूज अंदर से. So she had a look at it and she said, you are right. Iske venous phase mein, which has been missed in the referring hospital, there is contrast in this. So it cannot be a solid mass. Number 2, the answer to your question was that intrapericardial lymphoma, and this is like doing like I've done thoracic for 20 years. Intrapericardial lymphomas are like hen's teeth really. So you don't get intrapericardial lymphomas. This is the child who had induction chemotherapy and was declared disease-free on successive imaging actually. So I was not convinced that this was a lymphoma. So brought him in, had a look at it. And when we saw if you see the arterial phase of the CT scan, you would see that there is nothing going into the mass. But when you see the venous phase, you see something filling in it. But we were not convinced, so we brought him down and did an ultrasound. So this was Eid holidays. She came from home and we did an ultrasound and she said, this looks solid. I was still not convinced actually from my training. I said, no, I still think there's something in it. So we brought him into the theater. We had the bypass on standby and we were looking at the mass, trying to see if we can take it off. The pulmonary artery was completely bowed anteriorly. This was sitting in the transverse sinus. But when he became unstable, we put him head down. So Munir, you're coming to your question. There's a question, and anybody, I think, and everybody should ask actually, that why did you not cross clamp actually when you saw the LA roof defect? The problem was this kid was already on jet fuel actually when we put him on the bypass. So my anesthetist had already escalated the adrenaline and noradrenaline to like 1 mic and 1 mic each. I had already done a sutureless repair of the left main coronary artery. And we just had seen this. We kept the heart full basically and in Trendelenburg position. And we had read these few literatures just a few weeks back actually. So we said, we'll just keep the heart full and patch this actually. And that is what we did. But it is still questionable and open to floor for critique and input. Thank you.
Thank you very much, Dr. Waris, for feedback. I think we'll take last question from Dr. Fiza. Please conclude in 1 minute, then we'll proceed.
No question. There is just a suggestion to my junior doctors and residents that diagnosing mediastinal masses is not a very, challenging. Because if you know the normal structures in the anterior mediastinum, middle and posterior mediastinum, then you can go accordingly. Okay. So in your case, there was a middle mediastinal mass. So in middle mediastinal masses, the vascular anomalies and these, aneurysms and heart-related aneurysms, these are the commonest. So if you are taking lymphoma in that case, I don't think so. Okay, there is any literature of the lymphoma in the middle mediastinum, and if it's so, then it is a rare case and it should be a case report. And if you are thinking about the lymphoma, then in the anterior mediastinum masses, the lymphomas in your case, then that would be your first provisional or working diagnosis. Thank you.
Thank you. Yeah, I'm Furqan. There are one comments about that. Probably I would have considered 2 more investigation before proceed for this surgery. If someone has a lymphoma, I would have considered PET scan. And second thing, MRI scan as well to find out. And another comments about, I think the patch closer was the best option. We can't rely just on the ligation and put on the bypass on the left main system. Thank you.
So, sir, thank you for your comment. Like I've told you that this child was having ischemia, so we did not want to wait further for an MRI or something. We planned to go in. Thank you.
Thank you very much, Asif.
Thank you, Dr. Asif. So the last presenter of today's session is Dr. Zubair Mughis from PNS Shifa Hospital.
Okay, Assalamu alaikum, everybody. My name is Dr. Zubair, and I'm going to present today a case that we did in April, in which we replaced aortic root, ascending aorta, and arch in a young female who presented to us from a remote village. Coming to the case, she was a 22-year-old female, married, mother of 2 kids, who was a resident of Banu Aqil, who presented to us via OPD with complaints of shortness of breath on exertion for 2 months, chest pain, which was radiating towards back for 2 months, and fever, which was running on and off till this time duration, and neck swelling, which was again for 2 months. On examination, her BP was found to be 120 by 60 millimeters of mercury, pulse was 82 beats per minute regular, respiratory rate was 15, and temperature, she was afebrile at the time of presentation, and saturation of oxygen was 98% on room air. Systemic examination, on systemic examination, we found out that her GCS is intact, 15 by 15, and CVS, she had an audible diastolic murmur apart from S1 and S2. Chest was clear bilaterally with equal air entry, and abdomen was soft, non-tender. And regarding neck examination, there was found to be bilateral cervical lymphadenopathy with no visible veins, and rest of the examination was unremarkable. Thereafter, we admitted her in our HTU and our workup was done. Now, let me tell you that this is not the first CBC, because the first CBC and the second day CBC that we did in our HTU showed increase in the TLC count, and the first presenting TLC count was 17, apart from the fever that was running at that time 101. Other parameters were normal apart from ESR, which was 94 increased, CRP was 149, and LDH all were increased. Tropi was found to be normal, and so the CKMB, which was within normal limits. LFTs and UCs were also normal. RA factor was negative, and viral markers were also non-reactive. Seeing this, first of all, we did an ultrasound neck, which showed multiple enlarged cervical lymph nodes with eccentric intact fatty hyla, and these findings were likely due to infective lymphadenitis. At the time of presentation, we did a multidisciplinary approach, and infectious disease department was also on board. Regarding fever, they started Meronium and Vanco, both gram-positive and negative coverage. And with this, we started to notice that around 10 days post-admission, the lymph nodes started to regress and were completely gone by 14 days. And throughout this period, antibiotics were continued. Seeing this, we were planning, initially we were planning for lymph node biopsy, but seeing this, that the lymph nodes had got regressed, we again went for this second ultrasound neck, which showed that there is no lymphadenopathy. So there was no point in doing a biopsy. And at this time, fever had already gone. This is the pre-op ECG. Pre-op echo showed EF of 55% with a dilated aortic root, and annular size was 23 mm and STJ was 45. And aortic valve was thickened in structure and mobility and had severe regurg. Echo was repeated again after 1 week and showed similar findings with dilated aortic root of 57 mm and severe AR. This is the pre-op chest X-ray showing dilated aortic root and aorta. HRCT was also done, which showed dilated ascending aorta with a ascending aorta size of 6.6 centimeter and aortic arch of 5.8 centimeter in maximum dimensions. This is the pre-op anesthesia evaluation. Patient was operated on 6th April, and the operative findings showed hugely dilated aortic root involving ascending aorta and arch up to the level of descending and left subclavian artery. Dense adhesions were noted all around, along with the inflamed aorta, and aneurysm was involving the base of the innominate artery. Coming to the procedural details, incision, we approached via median sternotomy with incision extending up to the anterior border of left sternocleidomastoid for dissection of adherent aneurysm that we found was extending up till arch. As the aneurysm was very near the sternum, as I already showed you the HRCT, so plan was to cannulate femorals first and hypernize before sternotomy for safe sternal entry. Coming to the bypass, bypass was established by right femoral artery, and chimney graft was also applied on the innominate artery. I'll show you. Dual staged venous cannula and RA was also done. Sorry for the inconvenience. And antegrade and retrograde cardioplegia both were used along with topical ice slush for myocardial protection. We did AVR along with aortic root and arch replacement with a Valsalva valve conduit of a size of 21 mm. and open distal anastomosis was performed under DHCA. So here you can see the chimney graft, and we are cannulating with. Here you can see in this video, the chimney graft is anastomosed to the innominate artery, and then we are cannulating it with the aortic cannula. And then finally anchored it with silk. So the proximal aortic graft anastomosis was done using interrupted pleated sutures of Proline 40 after which coronary buttons were reimplanted. DHCA was established after we had done the proximal anastomosis, and it was followed by antegrade cerebral perfusion. The total DHCA time was 17 minutes. And on DHCA, we first examined the arch aneurysm's extension, and as there was no involvement of the vessels, arch vessels, then we excised the aneurysm tangentially, thereby leaving an eyelet for the arch vessels. And it was then followed by open distal anastomosis. After that excision of the distal aneurysm, it was the eyelet that we had created was attached with the conduit graft. This is the proximal anastomosis being done with the composite aortic graft. And here you can see and appreciate the numerous dense adhesions that we had noted while excising the arch aneurysm. Aorta was highly inflamed, and that was very hard to dissect. Here you can see that after examining the arch vessels, we decided to just make an eyelet. Here you can see, and the arch aneurysm is being dissected tangentially. And peroperatively, I would like to also mention that we were able to identify both phrenic and vagus nerves, but recurrent laryngeal nerve was unidentifiable due to dense adhesions that we encountered, and also the aneurysm that was strictly adherent to the base of the innominate. This is the video showing distal anastomosis that we performed on DHCA in interrupted fashion. Sorry for the view. And afterwards, when we had performed the distal anastomosis, then we inserted the root needle for de-adhering the composite graft after tying the sutures, of course. Weaning from bypass was smooth with moderate inotropic support of AD, NORAD, and Milinone, and patient was shifted to ICU. Post-op management strategy of ours also included empirical steroids. Prednisolone we started at the dose of 5 mg. Due to inflamed aorta that we encountered, are also the numerous adhesions, and also as there was no conclusive evidence regarding the etiology. Afterwards, overnight ventilation was planned after discussing with the anesthetist, and patient smoothly extubated on first post-operative day. These are some of the post-op chest X-rays done on operative day 1, first post-operative day, 3rd, 5th, and 7th. Post-op ECG was also unremarkable. This is the investogram. Here, the positive finding is the TLC that was raised on 6th and 7th post-operative days. Also, one thing I would like to mention, that patient experienced hoarseness of voice soon after extubation. We noticed that patient is having hoarseness, likely cause that we think that was due to the left recurrent laryngeal nerve that we couldn't identify during operation. So that was, we believe, was the cause of this hoarseness, and it got resolved spontaneously at about 1 week post-op. On 7th postoperative day, as regarding TLC, I already mentioned that it was significantly raised. It was 16 and 17, both on 6th and 7th postoperative days. So the 7th post-op day was the day that the patient developed fever of around 100 and 101 Fahrenheit, along with cerebral discharge that was coming from the lower aspect of the external wound. Pus CS was sent twice, both on 7 and 9 days, and both were negative for any microorganism. And meanwhile, ID consult infectious disease department was taken on board also, and their advice regarding antibiotics followed. Wound stitches, seeing that there is a discharge from the external wound stitches were opened simultaneously, and backpack dressing was applied, and which was changed daily in our ICU till we started to encounter that healthy granulation tissue has been achieved. During this time, the steroids that we were giving to the patient were stopped. This is the first pus culture report that was showing no growth. And when we encountered that after daily dressing for about 7 days, the patient has got some of the granulation tissue, then the resuturing of the wound was done. Delayed primary closure was done with proline. Meanwhile, rehab department and nutritional department was also taken on board, and nutritional buildup and cardiac rehab was also provided to the patient. Patient recovered well thereafter and was discharged on 28th postoperative day. And this is the histopathology report showing the specimen consistent to be the aorta. And the histopath was inconclusive regarding etiology and evidence, and there was no evidence of granulomar malignancy. And also, where we discussed with the pathologist, he said that there is no evidence of aortitis or arthritis in this patient. So we, at the time of presentation and how the patient behaved perioperatively when we encountered adhesions, likely cause we believe was due to infective etiology, but biopsy showed to be inconclusive. Hence, steroids continued to discharge also. And this is the patient's look at the time of discharge. Patient discharged without any complications on day 28th. Any comments and suggestions are welcome.
I'm Dr. Furqan from NICUD. Thank you, Dr. Mughis. This very nice presentation, nice case. What I notice in this country, that whatever the aortic aneurysm or aortic root aneurysm come, they are hugely dilated. Minimum when they come is 6 centimeter. I have done several which are between 8 to 10 or 11 centimeter. Normally, the strategy for this type of operation, what I use or the Western people use, is partial circulatory arrest instead of total circulatory arrest. So once you already attached a graft to the innominate, if I was there, I would have gone to the partial circulatory arrest. But well done. It was a good operation.
Thank you very much, sir.
Were you able to establish what was the actual diagnosis for the inflammation of the aorta?
No, sir.
I noticed you did the rheumatic factors, but did you do other autoimmune investigations like tests for SLE or AMA, antimitochondrial antibody?
So we didn't go for SLE, I agree. But regarding the etiology, at the time of presentation, when the patient got admitted in our ICU, and that time patient was running fever, I forgot to mention that at that time also perioperatively cultures were being sent, blood cultures were sent, but they were inconclusive. There was no microorganism isolated at that time also. And perioperatively, there was inflammation of the aorta and adhesions too, but there was no exudative fluid or anything like that that could have been sent for DR or some CS like that. So, and also biopsy was inconclusive.
But did you do any other markers for?
No, sir. Apart from CRP and ASOT and LDH, no other markers were done regarding a specific etiology.
And did you have a physician's input into this?
Physician was,
what they thought of the diagnosis?
We, before operating any case, there is a heart team comprising of cardiologist, cardiac surgeon, and cardiothoracic anesthetist. But at that time also, it wasn't discussed that we should go for SLE.
Right. Thank you. It was a wonderful presentation.
Thank you so much, sir.
And a beautiful case. Very well done.
Thank you, sir.
Congratulations.
Sure.
You are relating aortic aneurysm with the cervical lymphadenopathy. Being a thoracic surgeon, I'm still stuck to the cervical lymphadenopathy. ESR was raised.
Yes, it was 94.
Okay. And I don't think so that you have asked any TB workup.
I
And you
asked
did
for,
mention this.
I asked the patient and also the attendant regarding history of TB contact plus prior TB, because at that time I had in my mind that she is coming from Panu Akil, so might have been a possibility that she or in her family, somebody might have been tuberculosis positive, or there might be a contact history, but there was no such history provided. Seeing this, we were going for initially, as I mentioned, that we were going for cervical lymph node biopsy. But after 2 weeks of antibiotics, when we saw that lymph nodes are completely gone, then there was no point in doing so. And also the TB issue was non-positive, so we didn't go for that.
So is there any relation of aortic aneurysm with the cervical lymphadenitis?
That was why I presented this case. I have never heard about it any. I know the causes, the infective etiology, but I never heard of that some patient has presented with cervical lymphadenopathy. Suggestions are welcome from the audience if somebody has an experience of such aneurysm with cervical lymphadenopathy, of course.
You must search for references or literature too.
Yes, I agree. Thank you.
Distracted by the lymphadenopathy. That is probably an incidental finding.
Sure.
This is not an aneurysm which happened overnight. You know, this is a chronic aneurysm, 6.8 centimeter and extending up into the arch. So that lymphadenopathy is probably what got you to the diagnosis, but
Yes,
that is not related to your aneurysm.
absolutely right, sir.
And the other question is, did you all look into the possibility of a connective tissue disorder like Ehlers-Danlos syndrome or Marfan's or a morphinite type of a patient?
Sir, looking at the clinical features and the presentation, she was not.
You can have very few clinical features, but still you can have the gene.
I agree, sir, but at the time of initial presentation, she was running fever. She had symptoms of expansion, and also we were more towards like infective etiology in this young age, considering that the patient is from a remote area in Pakistan and is running fever. So we were more towards that, but yes, I take your point.
So we actually presented this case because she presented in general medicine OPD with fever and cervical lymphadenopathy and some shortness of breath. During course of investigation, she remained there, admitted there, and then somebody, dared to auscultate her, and she found that she's got a murmur. And then she was referred to cardiology, and then we took it over. Though she had an infective etiology, we tried to discuss it with our infectious diseases team, with the pathologist, with definitely cardiologist, everybody on board. But we could not find any identifiable cause. Immunological tests, definitely connective tissue disorders, since we do not have an investigation, so it was decided to at least relieve her symptoms. She has got a large, huge aneurysm, and it has to be dealt with first. We definitely will investigate, and for investigations, we have to send those investigations to A5P Rawalpindi. She is an entitled patient, so it will be cumbersome. So for the time being, the emergency is over. Whatsoever is required, we have done it. But for subsequent management, she definitely will be in our follow-up, and we'll take care of that.
Okay.
The only thing why we presented is because for aneurysms, we just wanted to highlight that dual arterial cannulation with one in the femoral and the other in upper part, maybe in axillary or with an innominate with a chimney graft. It is very helpful. It is a safety margin that gives you while doing a sternotomy. You can perfuse upper and lower body halves independently. It shortens your circulatory arrest time. Total circulatory arrest time in this case for our distal anastomosis was just 17 minutes. So after 17 minutes, you can restart your circulation. With the chimney graft, you can maintain selective antegrade cerebral perfusion. So it gives you a better outcome with dual cannulation, though it might take some time. Like axillary cannulation would take around like 30 to 45 minutes to establish, but this innominate hardly took just around 5 minutes. The thing that is required is just 8 mm graft, and you can use your routine cannula, straight cannula, 24 French, and you can make a Y graft with it, with the arterial line, you can pursue with that. So we just wanted to highlight that.
Excuse me, I have a question. I'm Dr. Ali Musa, being a fellow in NICVD. You did femoral cannulation, but wasn't there a risk of retrograde emboli concerning aortic aneurysm, because I've read about this.
I didn't
By
get your
femoral-
question.
Basically, by doing femoral artery cannulation, there is a risk of retrograde emboli or retrograde dissection, which is one of the complications of femoral artery.
No, we didn't encounter
In
any
acute
complication.
dissections, in dissections, definitely femoral cannulation can lead to retrograde circulation and risk of strokes. But this is just an aneurysm. Aneurysm does not have that risk.
Okay, thank you.
Sir.
Yes, sir.
Very well presented. These are like really rare cases and very challenging for a surgeon to take these kind of cases. In the West, people have gone away from, I won't say away from it, but there are options. I may just ask you, would you think of just debranching the head and neck vessel and asking your endovascular team to put in a graft from the femoral and cover it actually? So we would have done a good lot actually where I trained, that rather than going and dissecting the arch, taking the island of the head and neck vessel and then doing a distal graft, which I have to say, like, this is awesome, the way you have kept the antegrade cerebral perfusion going and did the whole thing. And it's very good. So number one is my first question is, would you think that there is something to be developed in Pakistan that we could do just debranching in these difficult cases and get our endovascular to put in a stent and we mark it for them just above the coronaries, that their stent can come all the way down? Number one. Number two is, did you have any literature on using the steroids actually? And because you only use 5 milligram, is there a literature supporting
Yes,
that?
sir.
First thing. Second thing is then when you have these big aneurysms actually, the diagrams and the cartoons look very nice actually, that you would go in there, clamp here, clamp there and take it out. But because of the enlarging size of the aneurysm, we know that there is a lot of aortitis that settles with time. You would not see it on the histopathology, but there is a lot of cicatrization inside in the aorta and outside in the surrounding tissue. So I won't be surprised actually that it was stuck to everything.
So regarding literature, yes, I searched the literature regarding steroids. There are some of the trials also. An American Heart Association article is there from 2015 that supports that prolonged pump time. And also when you encounter different adhesions and inflammation, then it is safe to use steroids. Apart from the wound infection, they have got anti-inflammatory properties and they are good to use. Apart from this, also an ongoing trial is underway, DEX, by the name of DEX2, that is underway. And initial findings are supportive of steroids, but in the long run, they are saying that with the basis of that, then we will be able to justify with supportive evidence that whether there should be a consensus regarding the use of steroids or not, because some of the articles are in favor of using steroids and some are not. So definite will be by the name of DEX2 trial that is currently ongoing. Regarding that debranching technique, I would like Dr. Nasir to please answer.
So actually, debranching definitely is an evolving technique, but it is especially useful in huge aneurysms where dissection is not possible, especially in redo cases where there is a lot of fibrosis, where there is risk of damage, risk of perforation, or anatomy is not visible. It was an option that was kept as a backup. If suppose there were dense adhesions, we do plan it multiple times before embarking upon this case. If we had difficulty in dissecting the arch or reaching beyond subclavian, definitely debranching would be a safe option. And we would have used that same, instead of 8O, we would have used like 10O Dacron graft and debranch the aorta, clamp everything, and you can restore the circulation. And when we can do it accordingly, we can avoid circulatory arrest in that case. If we can get an access to distal end and to the proximal heart and neck vessels. But since we were able to do it and we thought that debranching would increase our operating time and we can conveniently use this simply, so we did not. Yes, sir.
I think you are referring to debranching plus TWAR, like a hybrid technique, right? We have done a few in Taba, and the problem is the cost and availability. Right, it costs around like more than 5 million procedure for one procedure. And the other thing is availability. In last 2 months, I couldn't get a self-expandable stent inside Tabba.
Like I had done only one case in which we have done debranching on bypass. Yeah, I mean, before even starting on bypass, just apply a cross clamp, graft to left innominate, left common carotid innominate, and then graft it proximally to the root. And then you can just arrest the circulation, all the circulation can go and you can debranch it. It is an option, alternate option, but not the first option. First option is if you can dissect out the whole aorta and if you can graft it and reimplant it, I think it is preferable, especially in younger patients without any risk factor.
Okay, Dr. Shahab, I just want to appreciate the way you presented, you planned the operation, having a very good control of the circulation in your hand. But I would go toward the diagnostic and pathological again. Sometime you can request the pathologist because this is an aneurysmal dilatation and there must be something wrong with the connective tissue, even if there are absence of clinical fissure. So they can find some myxoid degeneration in the histopathological findings. Sometimes you have to go to the histology and ask them whether they can see that thing. So that is very indicative of, in young patient, indicative of a connective tissue disorder that can lead to such kind of malformation in the aorta. So that should be kept in mind. Thank you.
Thank you, sir. Thank you. Thank you very much. I'm again Dr. Furqan. Just the comments about that. Yes, deep branching like loopia using the loopia graft or frozen elephant trunk or just simple elephant trunk. They are the options available. But as you mentioned that the two problem here, number one is cost, very huge cost. And second thing, expertise available for the standing. If you don't have, then I think this island technique was the better option for this kind of patient. Thank you. Thank you. Sir? Yes, please. Sure, sure.
Hello.
Hello, yes, sir. Welcome.
Oh,
sir.
hi. Very good. Thank you very much. This is Professor Saeed Ashraf speaking.
Yes.
I'm grateful to Hasnat Sharif who invited us. To be honest, the presentation was very good. I'm really impressed the way the surgeon did it. I haven't met the surgeon myself. To be honest, whenever you do aortic surgery, I always look, where are you doing? What are the facilities available? And what will be the follow-up? These three things are important. And I think the surgeon did consider all those three things, did well, and produced lovely result. You can argue on all those things, but it depends where you're operating. In Pakistan, do all those EVR technique and branching, using radiology, vascular radiology, and like one of my colleagues said, to 5 million cost, that is just don't even consider. Do not. Just do. We are surgeons. We have got our two hands and thumb. Just use them and use our brain, and we'll get excellent result. I've only asked one question. Instead of femoral artery, I normally do axillary and center cannulation of the ascending aorta itself. Even I do all dissection with central cannulation and the TUE control. And third question, if it was advantage of diagnosis is that in a young group, if you know the connective tissue disorder, which is going to progress in the future, then naturally you have to avoid secondary problem like pseudoaneurysm and all those things. With island technique, it is well known in the world literature. And to my experience, I have two patients who developed later on 8 years and one is 12 years down the line, pseudoaneurysm of the distal anastomosis, and it was pain in the neck to go back. So I would have gone individual 3 vessels, direct anastomosis. Yes, it takes more. If you change the technique recently, we just do it even 24 to 26 centigrade technique. Yes, I agree with Dr. Shahab. I recognized him. That we will persevere with the diagnosis of histopathologist. There's no point just sending the specimen. You got to talk to them, make them, utilize their skill. Just come up with the diagnosis. Come on, mate. You are paid and you are working as a consultant histopathologist. Give us what is the proper diagnosis. This aneurysm and cervical adenopathy is 2 different things, in my opinion, after going through all your presentation. And thank you very much. Well done all. Congratulations to all participants.
Thank you, sir. Sir, regarding your question of discussing with the histopathologist, he was consulted multiple times and we were on board and we were persuading him to just come up with some credible biopsy report. But despite multiple consultations, this is what we got. Secondly, regarding post-op care, post-operatively, we discharged her on antibiotics, both gram-positive and negative coverage for 6 weeks. That is our protocol. And after 3 months, we get again a CT scan to look for any pseudoaneurysm and anything like that that you mentioned. And regarding the deep branching technique, yes, I take your point. But this silent technique was easier for us to do. And plus, regarding that axillary cannulation that you mentioned, 22-year-old female, short stature and all, we were able to do it quite easier with the femoral as compared to the axillary. But yes, people are doing this with the axillary cannulation and saving the limb as you mentioned. Thank you very much.
Thank you, Dr. Zubair. With this, our cases come to an end. I have been told to make an announcement that due to overcrowding in the dining area, we may go for high tea at 4 p.m. Moving forward, we have a health faced in cardiovascular and thoracic surgery. And the moderator of this discussion is Dr. Sanaullah. I request Dr. Sanaullah to please come and start the discussion and give the remarks.
Thank you very much, Hosh Muhammad. So everybody knows the current problems in the country. And because of these problems, we have got, I would say it's not the problem, it's the multiple problems that we are facing. Number one problem is the cost. The escalation of the cost has definitely affected a lot in the cardiac surgery. Everybody knows that. Number two is the availability. Despite even we are paying a higher cost for our disposables like oxygenators and the rest of the things, but despite of this, we are unable to find the things sometime. And number three, last but not the least, is that despite of giving a higher cost, we are getting the substandard things, because like the oxygenators without integrated filters and like this. So I would like to have feedback from our seniors. I would definitely take the advantage that everybody is sitting here and representing each institute. So I would like to start from our very extreme list, Professor Asad Evan Sab, Dr. Asad Evan Sab. So kindly, if you can comment on these, because you are representing one of the institute, that is the Public Institute and NICVD. So what are the problems that you faced in recent past regarding the cardiac surgery? Mike, please give them. So the topic of discussion is 3. Number 1 is the escalation of cost. Number 2 is the availability of the disposables. And number 3, the things that we are getting is definitely the other substandard. So if you can throw a light on these things, will be.
Dr. Sanaullah, thank you very much. You are right. The cost problem, as you are concerned about the cost problem in Sindh. But this is the problem in all over Pakistan, I think. And as working in NICVD, the cost issue has been resolved mostly due to the government help, due to the Sindh government fund. So in NICVD, being a surgeon working in a public sector hospital, I don't feel anything that what is going about the cost. So we have not to take care, or we have not to consider that thing in our setup as well. And I think that for every surgeon who is working in Sindh or anywhere in Pakistan or anywhere in the world, the cost should not be his consideration. It is my personal thinking that if because we are at a place where we have to give the very good result or a perfect result. So when we are thinking about to deliver 100%, then I think this cost should not be considered in our field. Its effect. So I will comment on it, that on the cost issue, that cost should not be considered a consideration for a surgeon. There should be the people should come up with some solution so that we can give a better outcome. Second thing you are saying is that disposables.
Availability.
Yes, it is a problem. It is a problem that we are sometime we are short of oxygenators, and as I think Sindh and whole Pakistan, everything in the cardiac surgery, every instrument, everything which we are using is all are made out of Pakistan. We have to import all of these things, and obviously there is restriction on these things, and about this the voice has been raised in Senate as well, that we are lagging about the oxygenator and all these things, and obviously we are getting the oxygenator, with sometime we have to cancel our surgeries, and we have to rationalize our oxygenator supplies to the satellite center as well, and in our center, and we have to restrict ourselves, and that's why our patients are suffering. And what is your third point? What you want to ask about?
Substandard.
Substandard.
Disposables, like we are getting the oxygenators that are without integrated filters.
Obviously, when we don't have the quality things, and we want to provide the care, then obviously you have to go on the substandard thing. Then you have to we are using some certain oxygenator which we have never used, or our perfusionists are suggesting us to put a intra-aortic balloon pump which is not FDA approved, not C marked. But obviously as a caregiver, we have to face these things, and we have to adjust ourselves according to that. But for ideal circumstances, I think these things like the cost or disposable or these things should not be the problem for us. This should not be our headache. That we should work all above it, and the government and all the social sector and all the human beings, they should provide us with all these facilities so that we can give our maximum.
Thank you very much, Asad Devan sir, for your feedback. And very good to hear that you don't have any problems like cost and other things. And I would like to add one thing, we being the cardiac surgeons, since the president-elect is here, I think we should make some sort of standards that will not go below this level. I think that would be beneficial into the future. I think so. Next, I think from the public sector, private sector, sorry, I would say from the Aga Khan Hospital, Dr. Solat Fatmi is here. I would like to have his comments that how can we come out of these problems? So do you find any a solution for this. So please have your comments.
So for the private sector, I can tell you from AKU standpoint, we have issues, okay? We have the issues with the money, we have the issues with the equipment and stuff, but we have been able to handle it as much as we can. Remember, 98% of the cardiac surgery is either CABG, AVR, MVR, or a combination of these. The rest are the 2%. So if you can handle this 98%, I think we are okay. So as far I can tell you, as far as getting the equipment is concerned, we are okay. We are blessed. We will not use the substandard stuff. We will quit operating, but we will not use anything which is not up to the mark. If we can't compare our operation with the North American standards, we will not operate at AKU. That's been the goal. AKU may the cardiac surgeries is a small portion of the entire growth. So we have the plastics, we have the general surgery, we have the oncology, we have the pediatrics, we have the gastroenterology, we have the whole thing. So pulmonology, itne specialties hain. So cardiac surgery is a small part, but we have been given enough resources to take care of it. So our challenges are very different than public sector challenges. Our challenges are more towards having those patients whom we can operate on, who can pay or whatever. AKU also has a great welfare system. About 2.8 billion rupees is last year of welfare. So we have enough supply of all those patients also, all that money to come to those patients. So our challenges are very different. How to come out of all of this and how the availability is there, whether we have the valves in place or not, whether we have other valves, I don't have the answer to it. The biological valves, the bioprosthetic valves are tricky to get, but now we are okay. Our director of our OR services, Dr. Waris, is controlling all of this, making sure that we have all our equipment, all our sutures, everything in place. We have our great purchasing department. So our challenges are very different from the private sectors, which are not university centers and public sectors. So since we are a small part of the entire university system and we have great supply chain or whatever, I think we are at a far better place than most of the other institutions.
Thank you very much, sir. This is what I wanted to hear. Okay, definitely we should not go for the substandard, and this should be adopted in every institute, I would say, okay, for the better benefit of the patients. And now I would like to say we're taking advantage Dr. Niaz Sumra Saab, who is the chairperson in thoracic surgery and the Dow University. So if he can share some comments with us.
Basically, same as Dr. Solid said, because the problems of the public sector hospitals is totally different from private hospital, because I am working at both places, and especially the problems are more in public sector hospital by keeping the turnover of the patients, their literacy and their presentation. They are usually coming very late. So, and with the complications, and by keeping the limited resources, manpower, availability of equipments, and the time, because in public sector hospitals, basically the time is also important, because after 2 p.m. and 3 p.m., people are not willing to work over there. And even our doctors who are residents and house surgeons, they are not willing to work with their interest. So as a manpower, it's very difficult to admitting these patients, handling those complicated cases. And whenever we take as a consultant those patients, it's totally our responsibility to manage them. And we take this responsibility on our shoulders. So multiple times, sometimes we need the permanent staff and permanent doctors to manage these patients to properly according to guidelines. Because nowadays the Sindh Health Commission is very active in these things, and documentation is public sector hospital. What I noted personally, in after making a lot of efforts, the people are very poor in documentation. Whenever there is a mishap, when we open files, we are finding a lot of deficiencies over there. And every time the senior is called to answer those things that has not been mentioned there. So this is very, very big problem in the public sector hospital. One is the documentation, lack of interest of people. We are getting complicated cases. And third, illiteracy of the patient, because the literate patients, when they are affording, they are reaching to private hospitals early in the hospital. And early presentation is easy to manage those diseases. But when they are coming very late with the complication, it's difficult. So, and the supply of the equipment, yes, always there is a problem. Because when I started VATS in OJA Institute of Chest Diseases, it was very difficult for me to arrange all those VATS equipments. I was begging in front of so many donors, because one donor donated the telescope, another one giving me monitor, another giving me light source, and even for a light source cable, I was begging from so many people. Although the university is supplying a lot of things, we are providing free food to the patients, we are providing free consultations to the patient, antibiotics and surgery is free, everything is free. But we start especially when the equipments are not over there. For example, in VATS equipments, the 0-degree telescope 10 mm is available. But whenever we need 30-degree, we have to arrange money. We request multiple times to our administration, and always definitely when the basic things are not available, then how can we provide these services? But alhamdulillah, with the help of Allah, we have made a lot of effort. We have arranged a lot of things in that public sector hospital. And when I started in 2012 in Dow University, OICD, and it was basic, we were operating initially the basic things. And Dr. Solat is the eyewitness. We both started over there. He was coming on every Saturday, and we were operating together over there, and we started work over there. Nowadays, alhamdulillah, at that same place, there is will, there is a way. We have started from the lymph node biopsies and windows and decortications. Now we are operating over there, everything. Decortication, lung resections, pneumonectomies, and lobectomies, with the mediastinal tumors, chest wall reconstructions, chest wall tumor resections, and esophagectomies. And because this is personal interest and effort. So in public sector hospital, it is not impossible to arrange all these things. But definitely there's need of a lot of efforts. For the government and in the private hospitals, yes, we have started robotic thoracic surgery in the private hospital, and we are enjoying robot over there. But still there are limitations over there because of the cost, our financial status, our country, the people are deprived of a lot of things. So even the robot which is there and skills are there, the gynecology and urology and general surgery and thoracic surgery is enjoying robot over there. But limitations, because in the last year, I just operated 5 or 6 robotic cases, thoracic cases. But total, I think 50 cases we have operated over there. But the reason is we are not able to operate because of the financial constraints of the people. And the supply of the equipments and standard of equipments is variable in setups, private hospitals. Few are the small setups, others are the large setups. We ask, we demand them, they can provide it. But from patient side, definitely we have limitations. And especially we try to adjust. And I think what I have experienced, the private hospitals are not compromising on their own charges. It's a surgeon who is compromising on his charges.
Very true.
So I think whenever the patient is coming to us, he's poor, he's rich. It doesn't make difference for us. We try to adjust them even by, we suffer, we manage them. But I think the supply of equipments is good, and the care documentation is also good in private hospitals as compared to public sector hospitals. So I request whatever the residents who are the budding surgeons over here, I will request them, please try to keep this mix sincere, be sincere with the patients and document everything, whatever you are doing. And we are doing more, we're writing less. So try to make this promise with yourself that whenever you start your practice, you start with this. And whenever you are sincere with your practice, doesn't matter you are working in limited resources, the people will come to help you. People are ready to help you. but definitely there is will. If you start with, the people are ready to help. So I'm also thankful to Dr. Solat because he has supported me a lot from a skill point of view, from the support from he came, and for the manpower, the training of manpower. I'm thankful to him also. Thank you so
Thank
much.
you. Dr. Solat, you want to add something?
I just have a question from all the people, especially NICVD, TABA, SIUT, everywhere. What is your situation about the nurses? Our nurses are leaving right, left, and center towards Kuwait, Dubai, UAE. The good ones are going towards England and US. Right now, they are just going like crazy. What is your situation?
Dr. Salat Fatmin, thank you very much. It's very nice, and I am very lucky to find myself in a very comfortable position that NICVD has started a continuous hiring of nurses. We are hiring nurses like whole year, and they are leaving, they are learning, and they are leaving, and we are replacing them at their basis. So that is our strategy. That's on what we are working on. Thank you.
Thank you. So I would say one thing, definitely the problems that are faced by the public sector and the private sector are definitely poles apart. Sometimes when we open the diary of the patients who are on the waiting list, their waiting list is sometimes 3 months or sometimes it's the 4 months. And when their number comes, when you call them and you receive a message, say it's too late, the patient is already expired. So these messages sometimes push the surgeon to reutilize the things like wash them up and do the ETO, at least do the surgeries, give benefit to something. So I would say कि वो कहते हैं ना कि अंदाज़े बयां चूंकि मेरा शौक नहीं है शायद कि उतर जाए मेरी बात तेरे सीने में तो sometimes it's definitely the different problems faced by the different institutes and whosoever working there they are fine enough. And now I would like to say the Professor Rizwan Memon Sahab, I was coming to you, being heading the biggest institute of the Pakistan NICVD, to please give your comments.
Thank you, Sanara. I am privileged to work in private sector and public sector as well. So I know the different mechanisms and the way to works. I totally agree with Sola that the private sector is entirely different. Patient is paying and the hospital has got donations and everything. So there's their different domain really. Working in public sector is entirely a different phenomena. I am really blessed, and I was telling Solat earlier on as well that when I was working in Liaquat National Hospital, my main concern was finance. That patient, does he afford it or not? In NICVD, in last 5 years, I haven't asked anybody, do you have money or not? Do you have a place to stay or not? You just come to NICVD and it's all free. And just you need to prioritize according to the disease pattern. So we are lucky from that point of view. But the reality, of course, as you say, that country situation, financial restraint are there. And working in public sector, we are totally dependent on budget from government sector and the government positions. So it's very hard to get the budget from the government. And we are lucky that our director is so well connected, so he's getting money from the government. Now, even then, since after COVID, we have reduced our workload. Say we are working at 50-60% what we used to work in 18 and 19 before COVID and before this financial crisis. So the number of cases is gone down, of course, because of the cost and availability of equipment. So as you say that what's a suggestion? So suggestion, I would say, is to prioritize the patient. Prioritize means try to do left main disease,
Exactly.
or critical disease, critical aortic stenosis, younger patient. We should go for these patients. Now I had always argument in my department as well. Sometimes there are so many sick patients, like chances of mortality is very high versus there are patients who are sitting at home, left main disease, 30 years, 40 years with doable with good results supposed to be. So my suggestion is to, in this situation, we should go and look for those critical patients we should do first. And here we have another suggestion is to like off-pump surgery
Very true.
is another ideal scenario. I mean, at some stage, there were a lot of surgeons who are doing quite good. There was a way for off-pump surgery. Now we are gone down, but I should encourage our younger generation to involve in off-pump surgery as well, to face the financial difficulties which we are going to face every day. Regarding nursing, yes, Solat, we are facing the same problem. We are working almost on the half. In our ICU, the demand is like 70, and we have, at the moment, we are on 50, 45, and we are struggling with this. So that's why the quality of care may be affected, and the workload on the residents and the doctors are higher as compared to if we have a one-to-one nursing in surgical ICU. But of course, we are facing. You have medical school, nursing school in your hospital. There's one way to deal with this. We have recently opened one nursing school as well in NICVD to train our own nurses. But of course, you will face this problem, and everybody is facing it. Third thing is the substandard. My query regarding, there are in Karachi as well, there are certain hospitals where there are substandard work is happening. So my concern is always those hospitals really that is there any way society can control these issues so that these bigger surgery cannot be done in the smaller hospital when all the facilities are not available and the standard of care is substandard? Thank you.
Thank you very much, sir. I would agree 100%.
I'd like to add about something about nurses. For the nurses, I think there is something going on. Choti machli ko badi machli kha jati hai. Like that, something, some nurse trained some institute. Then once she becomes trained, she was offered some better salary, some bigger institute. Like suppose we have nurse trained in Gambat. He was offered better opportunity in NICVD, so he left. Similarly, from NICVD, I think many nurses are going for the Kuwait or Middle East. So something that is happening, we are training raw material. Once they become trained, they quit. Because we can't enhance their salary as per some bigger institute or bigger place. Is it possible for those nurses we are taking raw stage with no experience of the cardiac much? We can make some bond for 5 years, 10 years. If you are coming here, you are getting training here. And once you start to give us a benefit or reward or fruit, whatever you suggest, you are just leaving for some better salary. So can this thing be discussed in some forum?
Yeah, of course we can do it, but like, how can you do that? That's the biggest worry, really. They will sign the form for you, all right. But how will you pursue that? How will you legally, I mean, you know the legal system in our country, really. You need to hire, I mean, you need to face, go to the court against them, or how can you do that? It's very, very difficult. I mean, in Saudi, maybe, yes, you are right. It's a closed country, really. You cannot leave. You have your passport submitted. You have, you cannot leave without completing your term. But in Pakistan, where you can't get the right for the right person, how can you just do that? So, I mean, it's a good idea. Ideally, it should be, but it's, I don't think it's a workable.
My suggestion will be for this. For a nurse to apply some other institute, she need experience certificate from NICVD. Suppose some nurse applying for the Kuwait, she can't go proceed without the experience certificate of NICVD. So when you are appointing them, you make a contract sign. If we will not give you experience certificate until you leave before 10 years. If you are leaving, you can resign, but without the certificate.
I think it's unfair. it's very unfair for the young girls and boys not going and having their future. Look at the market right now. So I don't think we can change that. The only thing we can do is keep training, as our esteemed surgeon Bilal has said. We keep on training them and just keep on looking at the whole thing. Hopefully our situation gets better in the nurses. But I don't think anybody should be prevented of just improving their future. I think they should be okay just to go. If they want to go, then that's fine.
I think it's not unfair. Why? Suppose I started learning training in NICVD. During training, I have made a lot of losses with sutures, materials, because I am being trained. So I am being a costly on my institute. Once I become a trained, and even during training, I am being paid. And I am increasing the cost of my institute. Once I become trained, I am leaving my institute, going some other place because of some better salary option. I think this is unfair because the two harm. If I am trained surgeon, I join and then leave, then something else. In the NICVD, suppose a nursing staff which are appointed, they are most of the time, they have no experience of cardiac. Even they can't do the ECGs. But once they trained on the ICU bed, how many children become complicated because of these nurses? How many they cannulas they lost just to prick the children for their practice? This thing happening. Once they become competent enough, they say, okay, goodbye, I am going to the Kuwait. That doesn't look to be fair.
Dr. Iqbal, I respect your idea, but really, I am like totally against it. That yes, if you look at Pakistan overall, the only thing which can improve Pakistan is the human being, the strength that we have, the young people. So it is our responsibility, just to give them skillful person, right? We should just give them skill and let them go. Right? Let them go. Just don't think about yourself. You are doing it for your own self, right?
No, then who is going to take care of my children?
Sir, pardon,
There are
let
children
me
who are
interrupt
not
over here,
studying.
Iqbal.
Who is going to take care of my children?
I think we are going away from the topic. So please stick to the topic rather than speaking. And I'm sorry for that. Very sorry for that. Point well taken. Dr. Rizwan Saab said very well that we should cut down the patients towards what? We should concentrate more on the patients, those who are younger, family dependent, with the left men, rather than investing our resources with the patient who is 75 years old, like has got multiple comorbids. Where
Can I
there
say
is a costly,
something?
like we are in war situation, let's suppose. Under these circumstances, when and to whom will you operate? The one who is near to dying or the one who is the younger one? And there are higher chances of survival. So under these circumstances, point is very well taken. As Dr. Rizwan Saab said, I'll move towards Professor Tariq Azam Saab. But I would say one thing, I did my first bypass, coronary artery bypass grafting within 6 months of my training. So he was the person behind me. I would really appreciate his efforts. Our training was excellent, even before, after his departure, but he was the person who was always behind us. So I would like to have comments from him.
Thank you for your
story
kind
for
words.
many surgeons. That is story for many one. Not only you are one.
Exactly. This is why I wanted to highlight.
I was looking who was speaking behind me. Thank you very much for your kind words, Sanaullah. We have been looking at this picture from the hospitals and the surgeon's point of view. Why don't we change the angle? Let us look at this picture from the person who pays for his medical point of view. Okay. 50% of our population is below the poverty line. All right. From 50 to 80%, we have a population which is of the low income group. From 80% to 99.9%, 99.5%, we have a population which is of the middle income group. And from 99.5% to 100%, we have a population that can pay for their operations. Okay. So if you put this in other words, उल्टी हो गई सब तदबीरें कुछ ना दवा ने काम किया आखिर इस बीमारी दिल ने अपना काम तमाम किया. Right? So our population does not have the capacity to pay. Okay. Things are getting hotter. People are getting out of jobs. They are getting unemployed. Businesses are closing down. All right. Salaries are not going up, but the cost of living is multiplying manyfold. All right. So how does the patient pay? How does the patient pay, number one? And number two, the cost of the dollar is going up every day. So an oxygenator, which, for example, 2 years ago came for less than 50,000 rupees, now a third grade membrane oxygenator would cost around 150,000 or more maybe. Okay. The cost of a balloon pump catheter 2 years ago was less than 50,000 rupees. Now, if you put a balloon pump in a patient, he has to pay nearly 3 lakh rupees extra besides the cost of his operation. Where does he get this money? I mean, as Asad was saying, I don't have to think about money. Maybe he doesn't have to think about money, but I have to think about money because the patient comes and questions me. And for example, if things do not go well in theater and you need to put an intra-aortic balloon pump in, then you have to come out and talk to the patient again. And a patient who's already beyond his limits paying, say, 6 or 7 lakhs for an operation, if you tell him that he has to pay another 3 lakhs, he himself will have a heart attack. Okay, so it's not easy. I mean, things are getting tougher. Life is getting tougher. And in a private institution, things are different from what they are in a public institution. I totally agree. It's not the surgeon's job to think about finances. He doesn't have to worry about these things. Say, for example, in the Western world or countries like Saudi Arabia, where everything is available and all you have to do is ask for it and it becomes available for you to do your job. But for countries like Pakistan, where people cannot afford to pay, life is very difficult. All right. And things are getting more and more expensive every day. So and this is going to reflect towards the private hospitals more than the public sector hospitals. All right.
It's very
So,
true.
so it's discouraging in that respect. All right. People will begin to move away from private hospitals more towards public hospitals because the capacity to pay is gone.
It's very true, sir. Recently, the price hike is so much that
Yes.
people cannot come in the category, so they can operate in the private hospital. So we are getting more and more patients toward the public sector. And I would say one thing, I hear a lot of things from the public sector. मुझे कहते हैं कि sir, it's free. Why don't you repeat that on every day? मैंने कहा nothing is free, even in the government hospital. This should be noted. Nothing is free. So somebody is paying. Let's suppose what? Okay, if we send 10 samples of CBC in the morning of 10 patients, so it's in the waiting queue. So if you are sending 5 samples, somebody else would be doing CBC. So that is important. We have to take care of these things because we are the one who are utilizing into the public sector as well. So this should be taken care. Now I'll move towards Professor Akhtar Hussain Saab, who has worked for years and years, the teacher of my teachers, to give please comments.
Thank you very much for giving some attention to me.
Sir, I'm coming in line. Nothing is being
Yeah,
interpreted. That's why I'm sorry for
I
that.
appreciate that. What I want to say from my own perspective first is that I am actually on my way out. And you guys are there, or some of them are coming in. So you are encountering these problems a lot more than I am, because I have come to the stage where I know the limitations of cost and the non-availability of stuff and all this. And therefore, I have limited myself to what I can do. And I don't have any ambition of trying to do what I can't do under the circumstances. Okay. So as far as cost is concerned, when you embark on surgery on a patient, then the cost per se should not come into consideration. Okay, because you don't know how much the cost is going to be. 95% of the time you're okay. You do the job, it's get done, the cost is there and it's all falls in place. But the 5%, 10% cases, you may fall into trouble and then you have to increase the cost. So what I do is I tell all my patients that, it's a matter of explaining everything to them that, look, this is the cost in my hospital. And I don't talk personally to the patient about the cost anyway. The finance people do, because the patient will come back to me. If the finance people talk, then they don't come back to me. Okay. And everything is written down and explained that if there is a balloon pump to be used, it costs so much. If you have to stay in the ICU extra, it will cost so much and all that sort of thing. Even in spite of that, cost is a problem. Sometimes you have a unexpected cost. So I, from my own point of view, try to readjust it from my own expenses, or I talk to the hospital administration. I'm senior enough and I know the hospital people well enough so that we come to some sort of mutual agreement so that we have to treat the patient. We cannot leave the patient untreated.
Definitely.
So we have to treat the patient. Now we have to come to an agreement as to what needs to be done. How much are you going to contribute? How much am I going to contribute? Fortunately, I am at a stage where I can do it. I have a lot of young people, they cannot do it. They cannot afford treatment of patients who need out of their own pocket, So in my perspective is a slightly different. But the other thing is the availability of equipment, like in private hospitals like mine where I work, tissue valves are not freely available. And I may not get the size I want. So I don't implant tissue valves. And I tell the patients that I don't implant tissue valves. If you feel that you need a tissue valve, please go and have it done somewhere else. I will not force anybody. And likewise, any other opportunity that comes and I can do it, but I feel that it should not be done because of the cost involved, I will not do it. I'll just refuse. I'll say, you can go somewhere else.
Very true, sir. We cannot leave the patient in the middle of the treatment. Definitely, it's the surgeon or somebody has to contribute to complete that. Very true.
What I want to tell the young people is that have a humane approach. If the patient needs your help, then help them.
Then a wholesome approach.
Not only, like patients like at ICVD or Khan, it doesn't matter. You don't need to give any personal contribution. But in hospitals like mine, I sometimes have to do it. I'll do it happily because if it needs to be done, it's because Allah compensates, I mean, रिस्क तो अल्लाह ताला ने दी भी है और तुम्हारी आएगी, तुम मदद करोगे तो ज्यादा मिलेगा, नहीं मदद करोगे तो कम मिलेगा, ये तो हमारा अकीदा है. तो मेरा ख्याल on that note, I think I'll give the mic.
Very true.
to Arif.
I would say, Professor Arif Rahman Saab, first I would say a few things. Professor Arif Rahman Saab is the solution of all the problems. When I worked at an ICVD, we used to rush him. He always find it a solution, and his eye, even a minute things, is excellent. That's why I want to have opinion from him.
Thank you very much. Well, working in NICVT for good 37 years and seeing it grow from the scratch to the level which where we could do root replacements and congenitals and all those things. Then working in military setup in PNS Shifa, and obviously we are all involved in private practice. Problems are there. We know there are a lot of problems. But you have asked three questions. Availability of things. They are very expensive. And even at such a high cost, they are substandard. So I won't talk about this micro level things, but a more macro level management of this problem. and I'll contain myself to only these three questions. You see, the first problem is that what is a standard product? Unknowingly, we have decided that anything that is FDA approved is standardized. Rest of the world is substandard. No, it's not true. There are a lot of things which are being used in Japan, which are using in Europe, which are used by the Chinese, by Russians even. They are not FDA approved, but you cannot question their standard, their product, the quality of the product, or things like that. So we have to come out of this problem. Secondly, we have to see certain countries where these things were equally expensive, or they were banned in those countries, they couldn't import them. What was the solution by those countries? They started producing their own things.
Very true.
Today, we have aankhein band karke, we have decided that anything that is FDA approved, I'll just buy that. May it be an ordinary solution. In early 80s, I have seen in China, they used to have those glass bottles where in hospital pharmacy, they would prepare Ringer's solution or normal saline solution and fill those bottles and send it to the wards to be used there. And empty bottles were sent again back to the end. They were performing open heart surgery at that time, giving reasonable results. So I know this is not our job, but as humans, we have to contribute to the society. We have to create some awareness to this level. Now, this is just one thought-provoking thing, which I'm giving an example by this Chinese method. Iran could not import anything. What they did, they imported one monitor making machine from Germany. They started making their own 4-channel monitors. And I tell you, we had those monitors in NICVD, dust cheap, and very good monitors, better than anything else. So what we need is this lateral thinking. We have to come out of box and think something more constructive. Then another aspect. Why institutions like NICVD, why institutions like Aga Khan Hospital cannot work on homographs? What is the high science? I mean, you can just develop a small laboratory under the same umbrella and start bringing homographs, producing your own homographs. Kitne log mar rahe hain sadkon pe? You shouldn't be short of those homographs. Then why cannot these institutions can have small interactive sessions with industrialists to bring some awareness? Do you know, ये जो pledget हम use करते हैं, Teflon felt use करते हैं, that comes in 4 feet by 6 feet sheet, and the cost is about 40,000, 30,000 rupees. Just imagine the number of pledges you can produce with one sheet. We are unable to take those initiatives. Another thing, when talking about coming out of box, Dr. Tariq Azam is a witness, and I'm sure you have already worked on that. We used to have, we started reusing intra-aortic balloon.
I remember, sir, yeah.
And we developed our own protocol. And Tariq Azam
we had a paper on it,
presented
sir.
those papers.
I had a paper, yes.
You also had a paper. You see, you saved lives.
Exactly, sir.
But today, our own colleagues are skeptical about it. That is natural. But since this thing is not being practiced in US or Europe, so it is totally discarded. That should not be the approach.
Very true, sir. Very, very valid point. We should start thinking on this thing. We should introduce the
That's
things
right.
ourselves rather than depending on the other countries.
Right.
We-
So just before I close down, the last, I'll give you an example. When cardiac surgery started in Pakistan, I'm talking about late 70s and early 80s. We did not have the money to buy oxygenators. And what we did was we used to have 2-3 patients of the same group, get their blood arranged. All the donors were also cross-matched. So we used one oxygenator, and mind it, it was a bubble oxygenator. And we used to do 2 or sometimes 3 operations with the same bubble oxygenator consecutively on the same day. Usually 2, because we were very slow at that time. So bubble oxygenator won't be, if it won't work beyond 2.5 hours. So we would quickly perform 2 operations on the same with the same bubble oxygenator. I'm not proposing that we go to those days, but at least
something should be.
Those were the people who thought out of box and found out of a solution. Today we have stopped doing it.
Thank you very much, sir. Thank you very much, sir. We are running short of time. So my apologies to Professor Hosseini Saab and Dr. Hassan, Dr. Nasir, Dr. Misak. I'm very sorry I could not take your point because lunch is ready. So hope you don't mind. We are Mudassir. Sir, okay. This time I think we got the message. Dr. Misak.
Thank you, sir. It's a great opportunity to be able to speak in front of so many people. I do agree with a lot of things, as sir said. The first thing is, if there's a will, there is a way. If you think that you wish to do something for a patient, every arrangements are done. Costs are even carried out. There are many people who are there to help you. And adjustments have to be from both perspectives. It cannot be only from the hospital side. Even doctors have to put their share in. Doctors even have to be able to contribute. And I do agree with sir on one thing, that if there are limitations in public sectors, then things that can be reused, there's no harm if you correct them in a way, and if they're okay, sterilized in proper way, do reuse them, because at the end of the day, it's important that proper treatment is provided. And yes, in JPMC, speaking from in a government hospital, your communication with your administration has to be very important. And if that is there, then everything is achievable. You know, when we started, we had all these issues of equipments and not proper instruments not being available.
Can I talk?
Decided to work, and for the patients, everything was made available.
Very true, Misak. We can raise the standards of reusing even eggs. How to reuse, that is also important. No? So Dr. Nasir, please, if you can.
Thank you very much, sir. So it is a universal phenomena. I mean, it's not specifically related to one group of people or a hospital or a region. It's a global phenomena. We are all going through it. But we must stick to few principles. I mean, if you're not getting standard things, we will quit cardiac surgery. No, we must not quit it. Things must go on. Always try to think out of the box. I mean, like you are quite senior people have, I mean, come up with very good suggestions, but we must not stop doing it. Wherever there is a will, there is a way out. And we must start, I mean, keep on doing it. Things definitely might go more worse, but we have to continue and we should work and we should help each other devise strategy to a new development, and we must continue with it. वो एक शेर है ना कि कौन कहता है कि मौत आई तो मर जाऊंगा, मैं तो दरिया हूँ समंदर में उतर जाऊंगा, एक रास्ता खत्म है तो दूसरा आ जाएगा, बीटिंग हार्ट शुरू हो जाएगा, कुछ ना कुछ होना चाहिए. Thank you.
Okay, Dr. Hassan, please have your comments.
Most of the things has been already discussed by all the people. Like we don't have a perfect concrete solution for this at the moment, but I like the talk of Dr. Arif and the suggestions given by
Can I
him.
say something?
The problem is not FDA. the problem is the drape. The problem is in the commission. And I don't think we have any representative of that here in this forum. Like if we have to actually get approved something, we have to talk to them. Like the government has to take some actions, not us. Like it's difficult to actually agree drape on those Chinese or Russian or any other alternate options. The other thing I was thinking about is the main problem I am facing, we all are facing, is the valves. This problem is, I don't think it will ever solve, right? I came up with a solution, a sort of solution. I read some papers, and the thing I actually experienced in my practice is, for the aortic valve, we encounter the small roots. Most of the times we don't have the valve of that sizes. So the most of the people in the West, especially Cleveland, is doing Ozaki procedures, right? And they have a very good result of it. So I am actually planning to go to Japan to learn this Ozaki procedure for a time being, for like maybe 3-4 months. And maybe we can start that here, because in low roots, they have a very good function. Like they perform very well, almost very less with very less radiance. And in 2022, the Cleveland actually published those results. They have opted Ozaki procedures. They have done like more than 1,200 procedures in the last 10 years. So these kind of solutions may be the answer to
Great, Sharon. Yeah, very great. So concluding remarks, please, Dr. Iqbal.
About Ozaki, just I like to clear this. It is a repair procedure required a template. A template itself is very costly, even more costlier than your mechanical valve or bioprosthetic valve.
The template is just one time buy, right? There is a stencil you have to buy just for the one time, and you have to use the pericardium. It has been shown, like you can even use the auto.
You always use the pericardium. Yeah, you can always use it.
You don't have to buy it again.
I have seen it, but in the Malaysia, they have practiced, they always open a new template for the patient. This was not, I have seen that they have practiced reusing the template. But I agree with you, that can be reused. Regarding about the things that you are telling me, I agree with that. We are cardiac surgeons, are the part of this same country. We have same problem everywhere, the same problem. In cut short, regarding about the cost is major issue. Things are available sometimes, but they are so expensive that we can't afford it. So question is that, can we not change our practice? I know many of you may strongly disagree with me. Why? A simple TAVI costs 25 lakh, 50 lakh, doing in 70, 80 years patient. In that amount, how much mechanical valves we can arrange? So if we have a small chadar, तो क्यों हम अपने पाँव बड़ा करते हैं? We have एक पूरी कम्युनिटी को ओवरऑल पार्टिसिपेट करना पड़ेगा। ये अन्ना का मसला नहीं कि कार्डियक सर्जन ही पार्टिसिपेट करेगा कि मैं रीयूज करके गुजारा करूं, ये करूं। सो जैसे अभी मेलोडी वाल की बात हो रही थी, इट इज वेरी इजी टू से मेलोडी वाल। जिस मुल्क में आटे की बोरी के लिए बंदा मर जाता है, उसको बोरी नहीं मिलती, उसमें हम मेलोडी वाल की बात कर रहे हैं। We have to think what we have in our shelf. मेरे पास पैसे एक रोटी खाने के नहीं, or majority of our population. I'm not saying there are some elite population, but this is, I think, in the fractions of our population. We have to think where we are living, and we have to thought out, not something like out of box, something like involving whole the box, whole the community, not just concising ourselves, no limit karo ye cheez, no limit karo wo cheez, is tarah karo, wo karo. हम एक जैसे ECMO की किट लगा देते हैं to save one life, it costs 25 lakh, 20 lakh. इसमें कितनी आप ऑक्सीजन डरा सकते हो, कितनी जानों को आप बचा सकते हो? नहीं, मुझे तो वो एक ही जान बचानी है जिसमें ECMO लगाना है।
चलिए, थैंक यू।
बहुत से लोग मुझसे डिसएग्री करेंगे, they don't agree with me.
नहीं, agreed with you, इकबाल। मुर्गी नहीं खिला सकते, दाल तो खिला दो। Putting an elevate in 80, 90 years old, definitely we have to think about it. Proceeding ahead. Handing over to Hosh Muhammad for further.
Thank you everyone. It was a healthy discussion. I'm thankful to the panelists for being here. I request them to please be seated with the audience so that we can proceed for the prize distribution. Yes, sir. I request Professor Mudassir Iqbal Dar to present the certificates and souvenirs to the presenters. Dr. Anam Asif from Jinnah Postgraduate Medical Center, please come to collect her certificate and souvenir. Sir, sit. Sit. आप हमें दे दीजिए. Dr. Zara Shirazi from NICVD. Dr. Shehzad Ahmed from Lakan National Hospital. Dr. Hasibur Rahman from Aga Khan University Hospital. Dr. Zubair Mughis from PNS Shifa. Thank you, sir. The decision have been made of the first, second, and third position by the judges. I request Professor Akhtar Hussain to please come and announce the names. So the names have been displayed. The first prize goes to Dr. Zara Shirazi from NICVD. Second position is for Dr. Hasibur Rahman from Aga Khan University Hospital.
थैंक यू डॉक्टर अख्तर साहब, आपने जो है ये एक नई रीत डाली है हम सब लोगों के लिए, हम आपको अप्रिशिएट करते हैं और बहुत बड़ी बात है ये। इसी तरह जो हमारे दूसरे सर्जन से उनसे रिक्वेस्ट है कि वो भी आगे बढ़ें और इस कोर्स को जो कि हमारे बड़े स्टूडेंट जो है कर रहे हैं और प्रेजेंटेशन कर रहे हैं, इनको एनकरेज करें। इनको जितना भी एनकरेज किया जाएगा उतनी जो है ना हमारी ये चीज़ें जो है ना आगे बढ़ेंगी और लोग जो है ज़्यादा से ज़्यादा पार्टिसिपेट करेंगे और प्लस ये कि रिसर्च इंटरेस्ट जो है ना बहुत ज़्यादा इंक्रीज होगा इंशाल्लाह। थर्ड प्राइज है उसके लिए भी अभी किसी को मुख्तस किया है, क्या नाम है?
Dr. Zubair Mughis from PNS Shifa.
That's very good. I really liked it.
Thank you, sir. For concluding and closing today's session, I request Professor Mudassir Iqbal Dar to please come.
Sorry, I'm taking the mic just for a moment or two. You all probably have heard in the news about some very unfortunate thing that happened to one of our friends and colleagues in cardiac surgery. Let this be an example for us. I want to stress on the younger generation that we all know that cardiac surgery is full of pitfalls and we can have problem at any time. Now, there was a friend of mine who's a legal advisor, and he said, don't worry about the patient, worry about the attendant and the file. So, I mean, you look after your patient, that's fine, to the best of ability. But things can go wrong. It is cardiac surgery and things can go wrong. So my advice to you all, younger people, is that keep the family in the loop at all times. Be honest with them, truthful with them, try to explain everything as best as you can. And then document everything. Document everything and make sure that they have understood what you are trying to tell them. If they don't understand, ask them to get somebody else who will. If they have a relative who have a doctor or something like that, then you can try and explain to them. And please document everything. Each and everything that you have said, you've done, please document so that there is no comeback. Because, I mean, you can't, it's not an act of negligence that you have done. It's something that has happened to the patient. You have tried your best to deal with the situation. But if you don't counsel the patient's attendants, and if you don't document everything, then you are liable to be deemed at fault, because then you can't prove that you've done something which you say you've done. And somebody can say, no, ये तो नहीं किया कि ये ऐसे नहीं किया, ऐसे नहीं किया, ऐसे नहीं किया. लेकिन आपने डॉक्यूमेंट किया हुआ है तो कोई मसला नहीं है, आप प्रूव कर सकते हैं कि आपने किया. क्योंकि अब जो है ना, हालात थोड़े से ये हो गए with the Sindh Health Care Commission. Anybody can put in a complaint to them, and I have been involved in some of the inquiries. They are very thorough in the inquiries, and then you are liable to get caught off. So be very careful. Okay.
Bismillahirrahmanirrahim. Thank you very much for coming over here in your busy day schedule, because today is the Sunday. Sunday usually we have a family day, but thanks for academic purposes, all of you are gathered here. This is a very great thing. I'm also thankful to Dr. Akhtar Saab that his generosity for doing this even possible to give up prizes to those who work hard. And we're also thankful for our president that he make his dream and the dream of many of our surgeons true, and many students dream true, that we are doing this great job. And we all gather, all the surgeons from interior Sindh as well as from Karachi are gathering together and sharing their thoughts. And there's a very good gathering. I appreciate it. I also appreciate that this time we did a new experience, that we just brought a younger generation to come forward to express their feeling and just to feel how to make a judge and how to become a panelist. This is also a very excellent thing, which in my opinion, as well as I'm very thankful for the Pharma Evo that they help it out in doing this program and make it too good for all of us. Thank you very much indeed for your very kind gathering. Thanks.
Thank you, sir. in last, the Farmio Limited has assisted to organize this event. So the senior marketing manager, Mr. Samir Iqbal, has to say a few words.
Bismillahirrahmanirrahim. The whole of the audience is right now waiting for the lunch. I'll be very true and crisp in this regard. First of all, our utmost gratitude to Dr. Hasnath for letting this event evolve from Karachi chapter to Sindh chapter. And FAMU has always been in front foot to support the academic initiatives whenever the imperative of doing so comes forward. And we want to stay, we want to go a long way, inshallah. And thank you very much.
Thank you. Thank you. Thank you, all of you, for being here. We can proceed to the dining area now. Thank you.
Thank you, Dr. Hosh Muhammad.